We are live.
A very good afternoon to one and all of you to our ARC webinar on top pearls in cataract surgery. The varied challenges and the learnings which are going to be posed in each of these videos is definitely going to ensure that you have a wealth of teaching and learning in store. We are lucky as always to have had true experts on the expert panel. It's unfortunate that Dr. Mahipal, our president, is not with us in this webinar. But anyway, we need to acknowledge the fact that he has taken AIOS to an even higher platform of learning in his tenure in these very difficult times. We have with us our past president, Dr. Ramurthy, who would definitely add to the wealth of information in this webinar as the webinar further unfolds, we'll know. We have with us our honorary secretary, Dr. Namrata Sharma, who has really brought in a very innovative learning for all of us, and in fact has bound us all together even more than before, enhancing the strengths of AIOS. Again, Dr. Sri Ganesh will be joining in shortly, who's the chairman and medical director of the Netradama Group of Hospitals, who would definitely add vigor to our discussions. Dr. Gaurav Luthra will be joining shortly too. He's the chairman and the medical director of Drishti Eye Institute, Dehradun, and also the IRSI chairman, ARC. And we are sure to see him adding greater dimensions to this webinar. We have with us our ever dynamic and a very prolific surgeon, Dr. Ajay Paul from BBI Foundation Group of Hospitals. Warm welcome, Dr. Ajay Paul. And we have with us, co-moderating with me, Dr. Satyajit Sinha, who's the chairman of the ABI Hospitals Patna and a very energetic member ARC East to be co-moderating. Before we start our webinar, go on to our first speaker, let us have a look at the encode video. This being specific to the glaucoma week.
We all know how difficult it can be to diagnose, treat, and manage a condition like glaucoma. As a leading ophthalmic pharmaceutical company, we've been actively involved in cutting-edge research in glaucoma therapies and formulation technologies for over 2 decades now. As part of our commitment towards this cause, we are delighted to announce the launch of our Free Glaucoma Therapy for Life campaign on the occasion of the World Glaucoma Week 2021. As part of this campaign, NTOD will commit to financially support 250 needy patients around the world with their glaucoma medicines for life. We thank the World Glaucoma Association together with glaucoma societies around the world for their support for this cause. This campaign aims not just to support those who are unable to afford their regular glaucoma medicines, but also raise the awareness of glaucoma, which is one of the leading causes of blindness in the world.
So moving on to our webinar, our first speaker of this webinar is Dr. Ameya Kulkarni, who's the Assistant Professor, Department of Ophthalmology, Bharati Vidyapeeth Medical College and Hospital, Sangli. A very comprehensive ophthalmologist with a great passion for teaching and surgical training. Let's watch his learning video. On to you, Dr. Ameya.
Thank you, ma'am. Thank you for the introduction. Okay, so today I'll be talking on tackling something that I have struggled with initially in the days of my surgery, that is the posterior polar cataract. Now, posterior polar cataract is very, it's peculiar because you cannot do most of the basic surgical steps that we all learn, and you can't hydrodissect, you can't rotate, you can't chop. So posterior polar cataract is slightly problematic for all the beginners like me. So let's see how to tackle it. Tackling the posterior polar cataract. Here, I'm doing hydrodelineation, only hydrodelineation. There's no hydrodissection involved. Once you do hydrodelineation, you can see there's a cleavage plane in the nucleus. It's It seems to be a very soft nucleus. Once the hydrodelineation is complete, you can see, you can't see a golden ring, but you can see that there is definitely presence of cleavage planes there. Once you have these cleavage planes, this is the trick. What stands between you and the posterior polar cataract is the nucleus there. If you take out the nucleus, it's just a matter of simple aspiration of the posterior polar, even if it's adherent to the posterior capsule, just a matter of taking it out by your irrigation and aspiration. Now, as you will see, what I'm trying to do is I'm trying to put my chopper. This is a blunt chopper. This is slightly elongated chopper. And here I just rotate my nucleus entirely without chopping it, without rotating it tangentially, so as not to put any pressure on the epinucleus plate and not to break the capsule. Then it's just a question of using some small amount of energy and taking out the nucleus. Once the nucleus is there, you can see the posterior plate is still intact. Or if it is adherent, you can take it out by irrigation and aspiration. So it becomes simpler rather than all the acrobatics you might have to do in cases of posterior polar cataracts. This is the last thing. You should actually touch that particular portion the last when you're sure everything else is taken care of. And this is how you can deal with a suspected case of posterior polar cataracts. Now, this is another case wherein you'll see that the cleavage plane that I got after hydrodelineation was slightly bigger. So that shows that the nucleus is going to be slightly harder than what we saw in the first case. So now how do you deal with this? You'll see that you'll have to take the nucleus out slightly out of the bag and then make sure that one end of the nucleus is in the pupillary plane and then the other end is still in the bag. You don't have to rotate it completely outside, and then you can chop because you're chopping away from the plane of the epinucleus plate. It's still safe to chop that particular nucleus. Once this, you're creating some space here, so you can take care of the remaining pieces. Once you do this, it's just a question of your normal phacoemulsification that can be done. And again, taking care of the last piece. At the end of this piece, you'll see that it's sort of unveiling your posterior polar cataract, wherein everything is still intact, even if it is adherent to your posterior capsule, it doesn't break. And even if you get rent at this stage, it's easier to manage than when the entire nucleus is there. And you just take care of this and it's done. So basically you need to take the nucleus out. That's what I do. That's the tip here, that you need to take the nucleus out and deal with the nucleus separately, and then go to your posterior polar cataract, which is more in the plane of the epinucleus. Thank you.
Thank you very much, Dr. Emma. That was a nice tip you showed beautifully. I'm going to be asking Dr. Amir a question, but I would want my expert panel to chip in too. Now, in very advanced nuclear grades, wherein it's difficult to prolapse out the endonucleus, and you can't rotate the nucleus either, don't you think it's a bit of a challenge to get your first fragment out? In those kind of situation, would you suggest there's a role of this inside-out delineation to be tried? How do you do it?
Yeah, in cases where the nucleus cannot be rotated out, as you rightly said, the inside-out delineation would be the way to go. It's slightly challenging to do for beginners like me, so I find this technique more useful. I don't have to change anything that I do normally in a phaco case.
Dr. Rajay Paul, Dr. Ramurthy, have anything to add about managing nucleus in these?
When you're doing a bit of harder cataract, as you showed, getting that whole nucleus can be as you have probably a simple, a little bit of not a chopping, but just holding it and separating it, or doing a bit of trench, making into half, and then getting it out. But I would do that instead of getting the whole. I saw the second case I suppose I saw that it needs a lot of visco to support it so that you don't bleed out. Because, and if you're having a harder cataract where the epinucleus plate is very thin, I mean, there the chances, if there is an adhesion there or if there is a break there, I mean, the chances of getting it down. So I would rather do a bit of trench, just separate it a bit, and then turn my phaco tip to this side and that side, and then take it out. I think you showed beautiful, especially the first case was absolutely fine. I would try to do it in my next cases, but then this is.
I thought so. Yes, that's a nice way of doing it.
Very nice videos, Dr. Amaya. The only couple of things I might have done differently is the size of the rexes, especially in the first case, when he scrolled it so beautifully, he had absolute control. So we ended up almost having a 5.56 millimeter rex. We didn't show the lens inside. In these cases, because you never know when you would have a PC blowout, I'd always limit myself to more of 4.5 to 5 millimeter rexes. So that just in case there is a mishap, you can get a good optic capture. The second thing, as Ajay said, is that the way you made the lens salute, though it worked very well in this case and in your hands, I think that too caused a fair amount of stress on the posterior capsule. I would also create a trench, just chop the nucleus towards the 6 o'clock and then chop on either side. And once I take out bits of the nucleus out, then the pressure inside the back is much less, in which case I would not even hesitate to rotate a little more. And of course, as far as removing the cortex is concerned, once the nucleus is out, it took some time. I would always do a visco dissection in these cases, because then there's no pressure on the posterior unlikely that the posterior polar cataract will give way, which makes the removal of the cortex a little more easier. Otherwise, all things beautifully shown.
Actually, my second question was, what is the opinion of the expert? Would you prefer to do a visco dissection in all your cases, or would you believe in doing a 360-degree stripping out of the cortex and the whole cortex and epinucleus comes together into a toto? Which do you feel is a better approach, or you can't generalize?
Chitra, can I just make a comment on the beautiful videos which were shown by Amya?
Yes.
I think he very nicely showed the fact that it is best to take out the nucleus first while maintaining an epinuclear plate at the back. And I think this has also been described very classically inside-out delineation, and also similar to that is the layer-by-layer technique of doing a posterior polar cataract. And the question that you said about visco dissection, I think visco dissection you can do, but each case is a little different. So you may not get away with visco dissection in all the cases. Maybe when you do it for harder cataracts, then it makes more sense, as Dr. Ramamurthy was also highlighting. But for softer cataracts, probably Amya showed the first case, which was very, very nice, how softer cataracts are to be tackled with the posterior polar cataract and manual phacoemulsification. Of course, like we all have graduated now, posterior polar cataract, if the patient can afford, I would rather go in for femtosecond laser than for manual phaco.
I think just to add a point, what I think Chitra was referring to was, how would you remove the cortex? Definitely, I would not do a visco dissection with the nucleus inside. But once the nucleus is out, because you have not done a hydrodissection, most often you would find that the cortex and the epinucleus is stuck, and it takes quite a while to remove them. So once the nucleus is out, the pressure within the lens bag is off. And in those cases, gently doing a visco dissection allows you to mobilize the cortex and the epinucleus and makes the removal of that a little more easier. I, as a routine, observe all the precautions when taking out the nucleus, but once that is out and the pressure within the bag is released, I go ahead and do a visco dissection to mobilize the epinucleus.
Anything to add, Dr. Ajay? Shall we?
Just to add that, when I have learned it over the years, when you are taking out the nucleus in a PPP, with the left hand we are putting in visco, and we try to inflate the bag as we come out. Now at that position, I learned that whenever I'm trying to do visco dissection on the cortex, the visco dissection is not happening. At that point, maybe lowering a little bit of visco escape so that the posterior capsule or the way is not too much of scaphoid state. It becomes a little bit flat. So you have a space, basically because of the visco already there, you don't have a space. So you don't get that good visco dissection. So if you make a little bit of visco escape and then do a visco dissection all around, I think it works wonders, as we said. Ultimately, there's a limited space inside the eye. So you can only give in as much as that eye can take. So that's a small tip over the years that I've learned, that make it escape a bit and then put in visco, and it comes out very easily.
Thanks a lot, Dr. Jay. And Dr. Amera, it was a truly nice video and very appreciative of the nice tip you showed.
Thank you.
I'm not sure whether Dr. Suvira has joined in, but Dr. Ashwin made a special request. Our speaker is in the cricket grounds, so he wants to come in second. So, Mr. Sunil, Dr. Ashwin, are you there?
I'm very much here, madam. Thank you for doing this. I'm really apologetic about this, but my signal is really bad. That's why I'm keeping my video off, so I can actually present.
I'm Dr. Suvira.
You can turn off the audio.
You can turn off the audio, Mr. Sunil.
Yeah, I don't need any audio. Thank you, Dr. Chitra, for allowing me to present.
Just 1 minute. I wanted forgot to introduce you. I'm very sorry. Dr. Ashwin Agarwal, I'm sure we all know him and doesn't need introduction. He's the Executive Director and the Chief of Clinical Services from Dr. Agarwal Eye Hospital, based at the Chennai Main Hospital. So let's hear what this very innovative surgeon has to show to us. On to you, Dr. Ashwin.
Thank you so much, Dr. Chitra, and the whole team to actually pull off something like this. It's beautiful. So yeah, let's go. Can we start the video? Yeah. So this is my challenging case, which I encountered, and I think Dr. Chitra was very clear. Do not show me a glued IOL case. So this is not a glued intraocular lens. But the idea of this showing this case was basically there's this phakic IOL for this patient, but the patient had ended up with 660 vision and was not happy with this phakic IOL. Two reasons. One is there was a huge amount of astigmatism from the corneal side, which was not being covered by this ICL. This surgery was done a while back, and the patient was completely unhappy about it. That's one of the tricks that I wanted to show was how do you remove an ICL. I really don't pull it out into the anterior chamber so much. I basically just grab it just an edge up, and I grab that ICL to remove it. And it is such a beautiful material, the Collamer, that it really just comes out of just a 2.8 incision. Post that, I think the cataract portion, I don't think is challenging from most angles for most surgeons watching this or on the panel over here. But the idea of showing this case was a couple of things. One is, how do you treat this patient post-operatively? Because the patient is coming to you for astigmatism, basically. So I'm doing a toric IOL implantation, but that sometimes is not enough in these cases. And what happens over here is basically, I'm putting a normal IOL in this case, and I'm going to show you over here how I'm basically taking care of that astigmatism using a pupilloplasty technique. That is a pinhole pupilloplasty, where I'm basically removing all the aberrations of the cornea, not at the corneal level or at the lenticular level. I'm basically trying to treat it at the iris plane. And if you see the, I'm sorry if I lost my audio. Yeah, so one of the things over here is to do a pinhole pupilloplasty using the single pass 4-throw technique. And what I'm trying to do here is, and that iridotomy is from the ICL surgery that was done long back. It's not created or hydrogenically created right now. Basically, I'm covering. What happens sometimes is when you close the pupil over here, you sometimes kind of get a shrunken, a small pupil which is not round. So sometimes what you really have to do is, after doing an irrigation aspiration, take off all the viscoelastic, because that's the real test of your procedure. So I'm putting a AC maintainer, and using a vitrectomy cutter, I'm basically trying to make this pupil a little round. Once I make it round, my edge to check where is the pupillary or the visual axis, this can be a little bit misguiding. So you'll probably want to put a mark beforehand. Is using the first Purkinje image, match the first Purkinje image to the pupil and that central mark which you basically created prior. to surgery. And once you're done with this, you get a beautiful result post-op day 1 itself. And this is something that we published, as well as we've been doing this for a while. But this is an idea and a challenging case which I think a lot of people will take benefit out of, because we have these IC8s and the other IOLs, the sulcus, pinhole IOLs, which are coming up, but they're still very expensive, number one, and they're not available. So what do you do till they become available, and how do you do it for these patients who are really struggling but are unable to afford it? So these are some of the scenarios where you can really use this. And I'm happy to answer most of the questions which I think Dr. Chitra will come up with.
That was a wonderful, very different thought process, typical of you, Dr. Ashwin. But coming down to other ways of dealing with it, we all are aware that if it's a toric IOL to be implanted, you need to have an orthogonal astigmatism. So what are the thoughts of the expert panel that if it is a little irregular in the 3 millimeter zone, would you consider doing a topo-guided surface regularization and then putting a toric IOL? I would want your inputs too, Anaga, on this. And yes, about that, I would want to know. And the other question is also, if it is a very irregular pupil, have any of you thought of using a contact lens on that irregular cone to make your phacoemulsification easier?
So I think, Chitra, I would agree with you completely that there are sometimes, severe ectasias where you are trying to do a cataract surgery. And if you don't use a contact lens on the top of the cornea during the surgical procedures, the whole things get so distorted that you can't make out, what is the real depth at which your phaco probe is and at what level is your irrigation aspiration is. So this probably will not happen in cases where the astigmatism is less, but would happen in cases where the astigmatism is severe. And also, if it is severely irregular, then again, this may happen. So I have done about 10 cases, 12 to be precise, using a contact lens for these severe ectasias. Regarding the topo-guided regularization, I think I would agree with you completely that if there is some amount of corneal astigmatism which can be tackled by first regularizing it using a topo-guided treatment, we would stabilize the cornea first and then take a final call on what the power of the toric intraocular lens would be. And pinhole pupilloplasty is a very good procedure, but I think it is still evolving. And although by just making the iris, making it into a pinhole, you can get rid of all the aberrations. But when would you want to do it, and when you would want to avoid it is something, which one needs to look at.
Couldn't agree more, Dr. Namrata. I think that's completely right, rightly said, because I think there is value in what we are seeing today, but how much and in what cases the selection is vital.
The other thing is, Dr. Ashwin, by using a vitrector, you have tried to enlarge the pupil, no? Do you think these pupils would dilate well in future for a retinal examination?
I think that's a brilliant question. So if you use the vitrectomy on the side where you're using the vitrectomy on the pupil, I think that side may not dilate as the opposite side might dilate. But again, having said that, these are those worst case scenarios where you don't have an option. So that's what I'm trying to get at. That you don't have an option. The patient wants to see the best. I mean, most of his time, the retinal investigation is something that we want. Yes, I completely agree with that. And I think that's also important. But at the end of the day, we want to also take care of what the patient.
Yes.
We want to take care of what the patient really wants.
I think for the purpose of the viewers,
Sorry.
Please understand that the best way to rehabilitate a keratoconus patient visually is contact lenses. If a scleral contact lens or rose scale lenses will give them good vision and they are able to tolerate it, that's the best way to go with it. It's only in cases where the keratoconus is stable and they are intolerant to wearing contact lenses or the vision, then we go in for phakic intraocular lenses. usually is toric lenses. And in these situations, it's extremely important to make sure that the cone is well centered. And how do you make out it's well centered? The posterior float should show that the nipple is within the central 3 millimeters. It's outside of that. The optical axis of the lens that you put in and the optical axis of the cornea is not going to be in sync. And that's when even contact lenses will not rehabilitate these patients adequately. And in my early days, I even explanted 2 toric ICLs because the patients were not happy with the kind of vision that they had compared to what they were enjoying with the contact lenses before the surgery was done. So this is something you need to bear in mind. And of course, the spinal pupiloplasty is something Ashwin has been promoting, seems to be a beautiful concept. Just a question to you, Ashwin, you seem to be putting in a toric intraocular lens. Is it really necessary when you have a pinhole pupil? I mean, will the cylinder also be taken care of with the aberrations?
That's a brilliant question, sir. I think the point over there is we want to be sure in the first few cases was what we did. That was one. And the point which I will say is in this case, I made a mistake. I should have said it before. This case, I put a normal IOL. I didn't put a toric one in this case. The specific case, I just put a normal IOL. I said it wrongly. But the point over here is, in the first few cases, what we did is we actually put in the toric IOL and then did the pinhole pupil because we wanted to see what the result was with that. And we compared it with this. I think we didn't see too much of a change at all with regard to which IOL you put in. But I think the number of case samples that we've done is a bit too small today to actually comment fully on that in the comparative this thing, because there were only 2 and 2 cases. That's not enough. I think we need to do a lot more comparative studies on this to compare whether you have to put in a toric or not.
Satyajit, would you want to ask any question at this point?
And we'll move on to the next speaker, ma'am. We have
about maybe Ashwin, what would be the challenges in doing a phaco in a keratoconus eye? A point or two you have to say.
I think the points which you all have brought up is absolutely right. The only thing I would like to add is it really, in these keratoconus eyes, they become really deep. So, and when you have those deep chambers, you really want to be making sure that your angle of the phaco probe from the corneal wound is taken care. And that's something, because when you go down that much, you're easily going to penetrate. And these are softer cataracts, very, very soft. So you just take care of not going down too much and allow the nucleus to come to you rather than you going and fetching for it. Do some more hydrodissection to kind of pop that one pole up and then try and do a tilt tumble technique or just change your technique a little bit for that. That's my only tip on these cases.
Can I just ask a question? Yes,
yes, Anaga.
Yeah, excellent video, Dr. Ashwin. And I just wanted to ask you, you took a suture at the end of the surgery.
Right.
Was that, yeah, would it impact the astigmatism in any way, or?
It was a stay suture. Honestly speaking, the reason I did that also because this patient was getting a little hypotenuse. I don't know why. Maybe my incision was not as great as it should have been. But I'm guessing that these keratoconus eyes, they are a little more stretchy corneas. And so you just need to, I just wanted to be safe for not having hypotenuse by the next day morning. That's my only reason. And it was more of a space.
Regarding your question, Chitra, about anything different in these cases while doing phaco, just one point I want to make is this. Very often the cones are in the inferior temporal direction. In extreme cones, the cornea is very soft there. So this is one of the rare situations where from a temporal clear corneal, I shift to a superior clear corneal, so that even my side port incisions are in the superior temporal and superior nasal, and leave the inferior temporal quadrant fairly untouched, because most often the weak cornea is right there. And
that's a very
lower intraocular pressures right through the surgery.
Yes, very good.
Yes. IOL power calculation also would be really very difficult. We are here doing pupiloplasty and we could be really off the target, because of the extreme keratoconus. I think that is another thing which we have not touched upon here. This was a video-based thing, but that also we need to look at.
Yes. Satyajit, do you want to...
Dr. Ajay Paul, you are muted.
You are on mute, sir. Can you please unmute?
Can I have a query for Ashwin?
Yes.
Ashwin, how small is that the pinhole? How
Yes,
much would
that's
you like to
superb
be
question.
that? No, no, I have a patient who is
Yeah.
post-RK, was almost 24 or 30 scratches are there,
Hmm.
very regular.
Hmm.
We have tried out all sorts of measurement, but could not find out whether toric is around 5, 6, 7 every time it's showing. So we did think of putting a single, just a spherical lens or a plain spheric lens, and then do a pupilloplasty. So just to take out this astigmatism. So what would be your size that you suggest? Because at the end again you made it a bit round because for that
Correct.
to be
Correct.
seen. So
Correct. I love this question, and I'll just answer very, very quickly, just in interest of time for everybody. But very clear, sir, RK has been one of our favorite topics in pinhole pupilloplasty because it has shown absolutely stunning results. The point which I'll say is 1.5 to 1.75 millimeters is, you cannot go more than that. I did a case, I made it 3 millimeters. I thought that's very small and that's very beautiful. But believe me, the patient was unhappy. The patient is unhappy with that vision. And unfortunately, what happens is we really have to get that measurement right, and we have to get it round. The problem, what happens is when you suture, it basically stitches like a cloth. The cloth comes together. You really have to go back and make that opening a little bit more with the cutter, or cutter is the best. A vitrectomy cutter 25-23 gauge, whichever you use, is the best way to make that pupil absolutely round. And all the three, if you're using a Lumera or anything, whichever you use usually, those three lights is the first Purkinje image which you see. If that matches into your pupil, I would obviously, if you're doing this as the first time, I would definitely go ahead and mark the visual axis before you actually go ahead and into the eye and do this. But mark the visual axis before you do that surgery. Number one. Second is make it 1.5 millimeters and then open up that pupil to that mark. And that is the perfect way to do this. And RK has been brilliant for us in doing pinhole pupilloplasty. Those patients are very happy.
thank you for those inputs.
Thank you, Dr. Ashwin. Wonderful video,
Sure.
wonderful discussion. Satyajit, can you go on with our next speaker introduction?
Thank you, madam. Thank you, everybody.
Thank you, Ashwin. We'll move on to the next speaker. Ma'am, we don't have Dr. Suvira with us yet.
Yes, so you go on to
So
Dr.
we'll go on to Dr. Sudang Bharti.
Yes, and Mr. Sunil,
Okay.
let me know if Dr. Suvira joins in, then we would, you may even call her, it will be a big help.
I'll call her after Dr. Sudang Bharti starts. So a very warm welcome to Dr. Sudang Bharti. Sir needs absolutely no introduction. He's our next speaker, and he's the chairman and medical director of the Bharti Eye Hospital in New Delhi. He has amazing pearls and he has amazing videos. He has been teaching for decades now, and we'll also benefit in this program from his amazing videos. A very warm welcome to you, Dr. Sudang Bharti, sir.
Thank you, Dr. Satyajit, and thank you, Chitra, for inviting me to this wonderful session. And I'm loving it since the beginning. So I'll be starting with my video. And can you see it?
Yes, yes.
Yes, sir.
So I'll be talking on PC rupture, the management of all kinds of PC rupture. And it has got sound, so I may not need to speak at all. A small posterior capsule defect without disturbance to vitreous can be converted to a posterior continuous curvilinear capsular axis using a specially designed forceps which can enter through a side port without disturbing the antechamber, causing shallowing of the antechamber. Antechamber is filled with dispersive viscoelastic and capsular axis is grasped repeatedly, and a small increment in rhexis size are done to provide good control on its size and shape. A single piece IOL is injected and gently maneuvered into the bag. Here is an interesting case of femtolaser cataract surgery. The main port is opened and visco injected to reveal a free floating capsulotomy. A routine maneuver to manage the nucleus is done.
with the default phaco settings when a posterior capsule defect is recognized. This is presumably caused by the laser cut technique onto the posterior capsule. Now, special care is taken that the vacuum buildup is minimal during the cortical removal. A single piece IOL is injected, allowed to unfold itself in the anterior chamber. And gently slide it into the bag without disturbing the posterior capsule and vitreous. In a large posterior capsule defect, as in this case, a structured disciplined approach is required to be implemented in these challenging situations. Maximum cortical matter is removed by aspiration. The retained cortical matter is the main cause of subacute chronic endophthalmitis and should be removed as much as possible. Special care is taken not to hydrate the vitreous. A specially formulated preservative-free triamcinolone acetate is injected from the side port into the anterior chamber to identify the vitreous. Anterior vitrectomy is repeated to remove the vitreous tags stained by the triamcinolone completely. A 3-piece intraocular lens is inserted and placed into the sulcus. It is dialed in front of the capsular axis. The optic capture is done with the anterior capsular axis. The viscoelastic is removed from in front and behind the intraocular lens. The capsule rupture can happen in hands of any surgeon. A planned approach is likely to get better outcomes without long-term complications. A dispersive viscoelastic is better since it is not sucked en masse and more often absorbed through trabecular meshwork, causing lesser incidence of raised IOP. Vitrectomy may not be required if vitreous remains undisturbed despite the size of posterior capsular rupture. Vitreous incarcerated in this section leads to retinal tears, retinal detachment, and endophthalmitis. An anterior vitrectomy is better for anterior segment surgery, along with staining of vitreous with triamcinolone for better visualization and complete removal from anterior chamber and corneal sections.
Thank you, Dr. Bharti. That was a lovely teaching video, and we'll be seeing different polar cataracts, but there is always a different tip to learn each time. Having seen your videos, you brought about this talk about creating a PCC in a posterior polar cataract. Now, we all know that the posterior capsule is going to be thinner, 4 to 6 micron, and more elastic than an anterior capsule which is about 14-16 microns. More so in a polar cataract, where the posterior capsule is actually supposed to be quite ready to slit vertically rather than its usual round. So this chances of doing a PCC in a posterior polar cataract gets limited to a fewer situations only, not commonly all. And if at all you were able to do a good PCC, would you want to only implant your single piece in the bag, or would you even consider availing of that Burgess space and doing a posterior optic capture in a polar cataract?
Thanks, Chitra. I personally would always, if it is possible to implant the IOL in the bag, I would still prefer a single piece IOL because of the centration issues at a later point in time. But if it is not so well, placed so as to kind of put the lens with the PCC. I can always do a anterior optics, anterior haptics, and then posterior rexis to be used as a optic capture. But personally, I would always, if it is possible to implant it in a bag, then single piece will be my first choice.
Single piece, I think, might be risky in polar cataract if there is a little big vertical split, because it tends to be a little more bulkier and the PC could give way.
No,
So
we didn't talk about the split. We didn't talk about that, because in that PCC, if there is a visible posterior, possibility of that posterior long split, then in that case, I would prefer Kiran's technique of making a oval rexis and then implant the lens along the opposite side, so that that's the best thing which I have come across to manage the IL placement if it is a vertical tear or a long tear. So then in that case, rexis plays a major role as to how to place the lens vertically and nicely, because that rexis gives me wonderful placement of the IOL.
Nice to have you joining us, Gaurav.
Yes, ma'am. Thank you for inviting me, ma'am.
Point.
Yeah, so
sir,
I think
in your second case, sir, you have showed that you have done vitrectomy with triamcinolone before putting the IOL. Is that your usual practice, sir? Or would you also recommend that after putting the IOL and then after constricting the pupil, then whatever vitreous is there in the anterior chamber, then we can stain it with triamcinolone and then do vitrectomy?
No, I always put it before. That's the normal way I do it, because I don't want to have any tag of the vitreous coming, remaining, and then causing traction and all those issues. And a majority of times when you're doing a vitrectomy, there's no possibility of upthrust from the vitreous. So if you have done it properly, and it is anterior vitrectomy, not I'm not going back and I'm not moving my probe a lot. So I think for me, anterior vitrectomy, with taking care that you don't tear or you don't damage the iris or the other things, the capsule and everything. I think my technique is to do the vitrectomy with the triamcinolone first, and in all these cases you need to have a optic capture with the rexis. That's what I'm doing as a routine.
Dr. Gaurav, what would be your take on this?
Yes, Satyajit, actually, I would also do a small limited vitrectomy if I notice that, I usually, if there is no vitreous presentation, I would not even do a vitrectomy. I would just do a primary posterior rexis if it was possible. But if vitreous phase is already broken and it's disturbed, then obviously, I would want to do it initially at that point, and then towards the end, making sure that there is no vitreous left, with triamcinolone staining.
So you would do it twice?
I could do it twice, as and when required. I never hesitate to do it, at whichever point vitreous is disturbing you. You should not continue to operate if vitreous phase is already broken and some of it is coming into the anterior chamber, just hoping that you'll manage somehow. I would always interfere right then. But the other thing I thought was that, Bharti sir, I wanted to ask that in the first case which you showed where there was a femto, you thought there was a femto, laser causing the break. Was that a posterior polar cataract? I missed that bit. And whether if it was a posterior polar, then what was the reason that you got the posterior capsular break? Or if it was not a posterior polar, then what might be the reason that we got this? Because, it was heard only right in the beginning when femto started 7, 8, 10 years back that we would get this. Was there, we usually leave a safe margin,
This is one of those cases, I think one of the first 50 or within 10, 15 cases. And I realized that this cut was primarily made by the femto itself when the whole thing began. And since this gentleman was not very old, so vitreous phase was very strong and it was not broken, and I could see that there was no vitreous presenting, and I realized that it was a vertical cut, as if it was cut by the femto laser. And this was one of the few cases, like I've seen a couple of cases where the rexis is not in the rexis plane, it's behind, and sometimes the whole complex of the laser cutting is slightly behind, so the rexis is not complete, and then there's a cut in the posterior capsule as well sometimes earlier. Now these OCTs are so accurate and everything is so perfect that you don't get these things. But this was very early, first few cases of mine, and this happened. This was cut by.
Thanks. In fact, that was what I wanted, take-home message. Nowadays we don't get to see this, and this was right in the beginning. So I'm sure this was amongst the first few cases.
Yeah.
Thank you, sir.
I wanted to clarify for the audience, I wanted an answer from the expert panel. What should be your ideal offset which you would use in a polar cataract so that you're truly safe from getting into any situation?
I use 800 microns. That's
I keep 800.
500 micron was, I've for the normal cataracts, I've got it down to 300 microns. But anything above 600, maybe 800, depending on preoperatively, if I see a very thick PPC chunk there, I would make it to 800, but obviously always over 600.
Ma'am, another change, I think.
Up to 1000.
Right. Ma'am, I wanted to suggest that other than the offset, it's important also to decrease the number of passes and decrease the energy, so that, you're using a technique of segmentation where you're not, going on for too long at high energies, because that causes cavitation. I mean, that causes the bubbles to form and that can expand the bag. So I use, a single pass, as Dr. Chi has explained, and it's working beautifully well last few months for me. And, using the right energies and shorter times and lesser bubble creation also is going to be very helpful in these cataracts.
Very right. Thank you very much, Dr. Bharti. That was a wonderful discussion. We shall now go on to our next speaker, Dr. Bansal, who's we all know is a medical director of Bansal Eye and Retina Center now, after having his long stints at PGI and also the Government Medical College of Chandigarh, where he's had years of experience. And I'm sure he has a wonderful learning tip for us. So let's get glued on to his video next. On to you, Dr. Bansal. Can you share your video? I think you should unmute yourself also.
It's okay?
Yes, right.
Okay. Thank you, Dr. Chitra, for the introduction, and also giving me the opportunity for this ARC session. So I'll be discussing one patient. This was a patient of diabetes. Like if we see in a diabetic, we can see different types of cataract. So this patient was a 45-year-old male. He was suffering from insulin-dependent diabetes over the last 20 years. He presented just within 1 day after sudden diminution of vision in the eye. And he had a similar attack about 6 months back. So visual acuity in this eye was just counting finger. He had a very intumescent cataract, so which I'm going to show how I manage this patient. Now you can see the color of the cataract in this patient, very intumescent and swollen cataract. So I was able to manage good rhexis in this patient. There was no liquefied cortex in this patient. So did about 5.5 to 5.75 millimeter rhexis. Just want to present the difficulty. See, this patient, despite very good hydrodissection, there is no movement of the nucleus or the epinucleus in this patient. So I did thorough hydrodissection in this patient. You can see here from almost all the quadrants, but however, there was no movement of the nucleus or the epinucleus. Now, another problem which I was facing in this patient was, you can see here, there was no nucleus in this patient. However, this epicortex and the cortex is so sticky in this patient that I tried removing this with the epinucleus settings also, but it did not come out. So ultimately I had to go in for the irrigation aspiration, and you can see how difficult it is. So I had to, every time I had to dig into the epinucleus and the cortex to move into the center and then only remove the cortex. See, now you can see how sticky is this. Not possible. It's not being pulled into the aspiration port. Unless I dislodge this from the area, and then only it comes into the center, and then only I'm able to aspirate the cortex. See, again, the last part of the cortex even is not coming out. So I took a risk even with the Sinski hook that I had to pull out the remaining cortex and then only aspirate. So see this, even the epinucleus plate is quite thick here. Very difficult aspiration. So even the last part of the cortex is very, very sticky. So lens implantation was not difficult in this patient. So ultimately we had about 618 vision in this eye and there was a moderate NPDR in the eye. So just want to highlight that how difficult sometimes it can become to aspirate the epinucleus and the cortical matter in a patient who is a diabetic, and especially if it is an insulin dependent diabetes and presents with a sudden onset of cataract. So just want to know how we could have done in a better way, because this patient took about 40 minutes for me just to aspirate the cortex and the epinucleus.
Thank you very much, Dr. Bansal. These are kind of situations which I'm sure all of us have faced at different points of time. But my thoughts are about this. If it is this kind of a soft cataract, I would definitely do multi-quadrant hydro, so that is one step, so that it takes care of those very dense corticocapsular adhesions. I would even think of doing a central trench and ensuring that I get my nucleus fragment separated in the center, and then the approach gets better. And I would even try a visco dissection. I wouldn't find myself very comfortable doing this for so long, because there is some amount of stress to the zonules which happen. It's not that I haven't come across these cases and I've done them similarly, but on hindsight, I feel that probably these could have been also the alternatives. I do want the thoughts of all the expert panel on this.
I did multi-quadrant right in the beginning, and still it was not getting free from the capsule. And as far as the nucleus is concerned, there was no nucleus at all. I first did use the phaco probe to see whether any nucleus is there. So ultimately there was no nucleus at all. It was all kind of a mixed up, you can say, epinucleus, jumbled up whole of the thing. So I had to just dig into the whole of the material to just push it out and then only aspirate.
Yes, yes.
I think you're right, Dr. Bansal.
Dr. Bansal?
Yeah.
How old was the patient, Dr. Bansal?
45.
Okay, even though it was a soft cataract at 45, there'll definitely be a formed nucleus. And I believe that the hydrodissection in diabetic cataracts is no different from other cataracts. If only we use the classical Howard Fine way of cortical cleaving hydrodissection, where you tent up the rim of the capsular rhexis margin. You did a beautiful rhexis and then do a multi-quadrant, as Chitra suggested. Most often you would mobilize the nucleus. And even in these soft cataracts, and even both for the removal of the lens material as well as the cortical material, I found that you use mostly the irrigation aspiration cannulas, and that's why the time taken. We need to remember that the bore of an aspiration cannula is just about 0.3 millimeters, 0.25 to 0.3 millimeters. While when we use a conventional phaco probe, it varies anything from 0.65 to 0.9 millimeters. So obviously, except in very extreme pediatric cataracts, I end up using, though I may not be using any power, I would use a phaco needle and do a phaco aspiration, both of the lens material as well as the cortical material and the epinucleus. And obviously, in these softer cataracts, it is possible to do with the irrigation aspiration, but then, as you said, it will take a very long time. When you use a phaco needle with a larger bore needle with adequate amount of the right kind of hydrodissection, most often this flows out easily.
I tried that first in the beginning by using the phaco probe, but still it was not coming. It was not getting sucked into the probe at all.
I think in that case, it might be because the lens was one single mass, and as was suggested,
Yeah, it was a single mass, I think. Yes.
Central groove, and then do something like a phaco flip.
Yeah,
You know,
yeah.
get a large nucleus and just prolapse out the entire material into the anterior chamber without using any power. Then you can just suck the material up.
Yeah.
Of course, there's different ways of skinning the cat, and what you showed was one of the ways.
Dr. Chitra, can I chip in? Yeah.
Yes.
Dr. Chitra, ma'am, can I chip in with the pearl? So I wanted to suggest that everything that you've said and Ramamurthy sir said is what you should try. What I do typically with these very resistant, sticky kind of cortex or a thick epinuclear shell which is not ready to come out, I go from the main port with my infusion, and I like to call it as a jet wash. And I just depress the posterior lip and let the fluid flow go into all the fornices of the capsular bag in the equator. And almost everything magically gets mobilized, and it just goes out. It's like hydro expression, and you are left with 90% of the stuff is all gone within seconds. And that only leaves few of the flimsy, attachments of small pearls of, like small cortical material, which is also loose and can be easily peeled off with the cortex, with the aspiration. So that's how I would do it, because, just increase the fluid flow. Go from the main port with your irrigation, depress the posterior lip, let the fluid flow from the main port freely, because if you do it from the side port, it won't work. Even if you try your best with the bimanual, it won't work sometimes, and it really helps me do these cases.
Oh, that's a good tip. I haven't tried it. So we shall do it next time.
Yeah, you want to see video from Gaurav? How you do that?
I have a very good video on this. Maybe next time I'll show this. I'm not in the, I don't have access to my videos right now. I'll try to see if I can present towards the end. Yeah.
So, Chitra, I think Dr. Bansal showed sometimes you can get into tricky situations like this. But I think all the phaco machines now do have a epinucleus mode also, which can be used with the phaco probe, and you can take out the epinucleus in the epinucleus mode, and the sticky nucleocortical complex will be easily dealt with it. But I think the most important thing, like Dr. Ramamurthy also said, is hydro. So I think although Dr. Bansal did show that it was done to the satisfaction, but still the lens did not move. So I think the critical thing is the lens has to move. Otherwise, things can get a little more prolonged than desired.
You can go back and do a hydro again after some time, even when you're doing it, and then try viscodissection. Those are different ways, and wonderful discussion. Dr. Satyajit, would you introduce our next speaker?
Yes, ma'am. We'll move on to our next speaker, Dr. Matthew Kurian. He's a consultant for cataract and refractive surgery at the Chaitanya Group of Eye Hospitals, and he will be showcasing our teaching today, the teaching pearl in this video session. Dr. Matthew Kurian, a very warm welcome to you.
Thank you very much, Satyajit. Thank you, Dr. Chitra, for having me as a participant in this one. I'll start with my video. I hope my screen is visible to everybody.
Yes.
Okay, so this was a lady who was diagnosed with a branch retinal vein occlusion and with significant macular edema, as can be seen in this picture. And there was multiple injections driven prior to the cataract surgery that was planned at a later date. So she opted for femtocataract, and you can see that we are focusing most on the anterior capsule there for the flap, etc., for the rexus, but I didn't understand the significance of this blob over here, which is visible also in the line scan. The offset here is about 500, which was my standard. The significance of that blob at that point, I didn't realize. Okay, so the initial steps of surgery were not very different, but I found that generally it was much more difficult to separate the fragments. And I do 2 circles and 8 spokes fragment, and that was not happening easily. And I was struggling a little bit. And suddenly, when I was very far from the posterior capsule, you can see that the posterior capsule has opened linearly like that, like in a posterior polar cataract. So anyway, putting this coat without letting the chamber collapse, and then switching between IA cut and cut IA, I was able to complete a good viscodissection, clearing the cortex and removing the vitreous from the anterior chamber. I then finally finish by putting a standby lens, in this case, which is a 3-piece lens. I prefer to use 3-piece lens in the sulcus when I'm doing an optic capture, and I'm able to complete a good optic capture and complete the procedure over here. This is the post-operative 1-week image, and this we published at a later date. So just a few things that I would like to take in terms of the tips. Normally, in any intravitreal, we should be suspicious that the posterior capsule may be damaged, and we tend to get a linear laceration, which may not cause intumescent cataract like in other lens studs. In all these situations, we should be prepared with a multi-piece lens, and I really like the cut IA cut option on the modern phaco machines, which allow for good cleanup in the event of a complication like this. Thank you very much.
Thank you very much, Dr. Matthew. You brought out a new challenge which we face with these multiple intravitreal injections which are given nowadays. I would actually, whenever there's a case of an intravitreal injection or a vitrectomy, I would always be prepared to treat these cases like a polar cataract and expect that there has been a lens touch and there would PC could give way. So then I would look at doing multiple hydrodelineations in these cases to have layers and layers of endonucleus so that the posterior capsule is well protected. And you didn't show that bit of that nucleus which was still there in the bag, and you know in that video you haven't shown us that. Probably this is a kind of case wherein you might have even thought of using an IOL scaffold when there's still some nuclear fragment there and the capsule is open and you are not planned for it.
Yeah, in my case, I was able to complete it using the visco shield as a scaffold onto which I was able to complete. It was not a very hard cataract. It was very sticky, and I think that was what was causing the challenge. It would not rotate. Maybe the exposure to the intravitreal injection molecule alters the lens fiber, what you call stickiness, and makes it a little more leathery rather than the typical response. So I knew that it was different. I couldn't figure it out at that point of time. And if you see at one point, you can see that there is this pigmented powdery white material on the epinucleus shell as it is flipping out of the bag. And I believe that that must be the chemical that is deposited over there.
Expert panel, any thoughts you have on this?
Ma'am, I would like to ask Ramamurthy sir, is the take-home message from this video that for every intravitreal injection that is given, when it's due for cataract surgery, a posterior capsule assessment has to be done through anterior segment OCT and be prepared for any adverse situation?
You could need to be prepared. But anyway, if you don't have an anterior segment OCT, you take care that the posterior capsule is open and continue with your case.
Sir, you are muted, sir.
You need to unmute.
Absolutely. I mean, I think it's an excellent question, Satyajit, and I was just about to develop on that in the sense that obviously when a diabetic retinopathy case, you would be doing a OCT before taking up the case for cataract surgery. And most of our OCTs today come with a AIOS-OCT also. And as was shown by the speaker also, most often you would find a PC touch or a defect, and you need to see if it is in line with the posterior capsule. Most often it's just a touch, and there may not be a break. There might be a fibrotic patch over there. And in these cases, you would get away without a PC rupture. As was seen in this case, if there is some material protruding into the vitreous cavity, most often you have to be prepared for a PC rent. And the second thing is that you have to also differentiate between whether it's after a intravitreal injections or post-vitrectomy. Because if it's after intravitreal injections, especially in younger patients, is most often you have formed vitreous and you can get away with conventional cataract surgery as well as doing an anterior vitrectomy, as was shown by in this video. But if it's post-vitrectomy and the lens touch has been there is no vitreous to scaffold the lens material. And these cases, the lens material rapidly disappears into the posterior segment, when you might have to call the help of a colleague to take care of that. And in case there is a posterior capsule touch because of an injection, I would actually allow a certain amount of time to elapse before going in for the surgery. Because if you allow a significant amount of time, there is fibrosis that occurs around the margin of the touch. And this helps to retain the lens material within the bag. The moment you get a cataract, there's no need to rush into the surgery and go ahead and do this. If you allow a few weeks to last before taking these patients up, you might have the capsule fibrosing and supporting the lens material within the lens bag.
Sir, I wanted to ask Dr. Ajay Paul, suppose I have recognized a PC defect in these post-intravitreal injection patients, would SICS be safer? Or would you still, you have seen a posterior capsule defect, would you still want to go ahead with phacoemulsification?
Not necessary. With the newer modern machines, with the Centurion and all, you can always get down your parameters low down. That depends on if you have a cataract which has turned white suddenly, you know there is a big rupture there. And if you have waited for some time, there is a fibrosis, you can still go ahead. But it's not necessary that, well, I do continue with the phaco and with the parameters down, knowing well that I might get a PCR, because SICS is also the same. When I'm opening the incision, the AC flares up and there could be the tear could extend. So I can extend with the, and normally in these cases, I go with the 20 IOP or 20 IOP and then go ahead.
I would still stick to phaco because I feel it's a very controlled environment, and you know, you have a closed chamber and the fluidics are good nowadays, and you have to be prepared with low pressure fluidics, and you have better control, and you are already prepared, just like you're dealing with a posterior polar cataract. However, as Dr. Ramamurthy sir said, you know, you have to differentiate between the post vitrectomy and the post injection. And I feel that, you know, centers which do a lot of retina surgery, we typically tend to post VR surgery, you know, we always do an IOL master or a LensStar to ensure that we have an axial length which is right, because sometimes the cataract progresses very fast. The second thing is, if oil has been used, the PC is very, very difficult to handle sometimes. You know, it might have a sheet which is sticking behind the capsule and you might want to polish it. And the moment you try to do it, it kind of gives way. So you have to be very wary of polishing the posterior capsule in these post VR surgery, post SOR eyes as well. And some of these injection eyes also have seen that the quality of the capsule deteriorates. The posterior capsule is not healthy anymore, especially if multiple injections have been given. So I think it's definitely a very challenging situation. And I've burnt my fingers a couple of times trying to polish these capsules, thinking that, you know, I'll get away. And it's also very difficult to make up, you know, posterior capsular rhexis because it's very friable. It doesn't tear the way that you would want it to kind of form into a rhexis. So Gaurav, of course, you know, it doesn't extend as fast as well. If you have a PC break, usually, you know, it'll just remain limited to small kind of a tag or something and may not run away because that upthrust from the vitreous is not there. It's a vitrectomized eye. So you can still put a lens in the bag. Even if you've had a small PC tear, it's not going to extend. So, I mean, you have to learn to handle these eyes, you know, over a period of time.
Let me rephrase my question for the benefit of all the ophthalmologists. I see a defect and I don't have a machine which has the advanced fluidics. I have a regular phaco machine. Do you still recommend I go ahead with phaco? Or
absolutely, absolutely. No, I would still recommend going in with phaco, but with lower parameters. You know, even on a regular machine, I think machines are good. It's important to have a great machine, but I think it's more important to know how to handle your machine, and you can, you know, kind of keep the bottle height low. You can keep your aspiration low. The flow rates can be controlled, and you can have non-leaky ports so that you don't have fluid flowing out and gushing out. So you have an uncontrolled kind of environment, and you can still manage these cases very well. I feel you can better manage them with phaco, but if you are not a skilled phaco surgeon and you are more skilled at SICS, then definitely do SICS.
Yes, that was
one aspect that I wanted to bring about was that when you're doing cataract surgery for these cases, and these cases have to undergo a vitreoretinal surgery, then what should be the time back gap between the cataract surgery and the vitreoretinal surgery? Because often for vitreoretinal cases, sometimes you do have to, do a cataract surgery first so that you can do a vitreoretinal. So the sequential kind of a thing. So is anybody, I know there are no retina people here. I mean, I shouldn't say that. Some of us do have retina experience, but what is generally the practice? Can it be done sequentially on a gap of 2 or 3 days, or should we wait for a longer period of time?
Actually, in our city, we do both phaco-vitrectomy in the same sitting.
Same sitting.
So
That's
I
what
do
we
not
do.
see an issue on that. The only time when I would defer and wait for a retina opinion with the cataract is if there is a macular edema, when they want to give the intraocular injection and want the whole eye to settle down and then go ahead and do a cataract. I don't see any reason why it can phaco-vitrectomy cannot be done simultaneously.
Actually, in our center, in patients who are 50, 55-year-old, even if it's an early cataract, we go ahead and do a combined surgery. Usually we do the phaco in the one theater and the patient is shifted to the next theater because the retina surgeon is more comfortable there and the place is set up. And they just go ahead and subsequently do the surgery in one shot. And that seems to work quite well. I believe that if you just do a vitrectomy surgery in these older patients, most often the cataract progresses quite rapidly and you end up doing a second surgery within a span of about 2-3 months. And when both are done by competent surgeons working in tandem, the results are quite satisfying.
So shall we go on to our next speaker? Our next speaker is Dr. Arun Kshetrapal, a very renowned surgeon for Prince Kshetrapal Hospital, Ajmer. And I'm sure he has a brilliant pearl for us today. Let's hear from him and then on to our discussions with him.
Thank you, Dr. Chitra, for introducing me, and thanks for giving me this opportunity. Am I audible to everyone?
Yes, yes.
Am I audible?
Yes, you are audible.
Okay. So I'm going to present to you a case of traumatic cataract. This 32-year-old female had sustained injury about 8 months back, and she came with a picture like this. The cortical matter was all fibrosed, and the anterior and the posterior capsule were adherent to the cortex. It was very difficult to perform a capsulorhexis. The anterior capsule was very much adherent. So after staining the capsule, I attempted a capsulorhexis. You can see that I failed in doing a capsulorhexis, but whatever I could do, I attempted it. Next, the cortical matter, the loose cortical matter, which was present in the equatorial region, was removed. And now the next step was to separate this fibrous cortex, which was firmly adherent to the posterior capsule. And I tried to create a cleavage plane between the fibrosed cortex and the posterior capsule. I was successful to a certain extent, but I did not want it to pull too much, because if I was pulling on too much, you can see that there's a stress on the zonules. So I did not want it to pull too much. I don't want it to injure the zonules. And if you watch here, while attempting, I made a PC rent. The posterior capsule got ruptured here. I hope you can appreciate that. So what I did was I abandoned separating it, and I went on to dissect it out and excise this fibrosed plaque, which was firmly adherent to the posterior capsule. Now, the advantage of this was that I was no longer putting stress onto the zonules. My zonules were safe. So if you have a thick posterior capsule or a thick plaque on the posterior capsule, which is not getting separated from the posterior capsule, the pearl here will be to dissect it out rather than pulling onto it, or you may lead to zonulodialysis. So this plaque was excised 360 degrees all throughout. So once the plaque was separated 360 degrees, I wanted to remove it. And if you can appreciate, as I was pulling onto the plaque, you can see the whole of the vitreous is attached to the undersurface of the plaque and is being pulled towards the plaque. So it was being pulled. So now pulling onto this plaque would have resulted into traction on the vitreous and retinal detachment. So the next step would have been to remove all the vitreous attachment from underneath the plaque. So you do a vitrectomy, you remove all the vitreous attachment from the plaque. You make the plaque free of the vitreous attachments. And once it is free of all the vitreous attachment, you can just easily pull it off and remove it. So the pearl here is don't pull onto the plaque if you have a vitreous attachment. I went on and did some anterior vitrectomy here to make sure that there was no vitreous in the anterior chamber, and went on to insert a 3-piece IOL into the sulcus. I tried to do a capture that was not a full capture. And of course, before closing the case, you need to check out that there's no vitreous in the anterior chamber. This is very essential. And if there is no vitreous in the anterior chamber, then you can close your case. Thank you very much for your attention.
Thank you, very much, Dr. Arun. This was a wonderful case, and the way you've shown it doesn't leave much place for discussion at all, excepting for the fact that if it had been a dense anterior fibrosed capsule, I would have thought there would have been for a role of a vitrector at that point of time.
That's true.
You were stuck with a thick posterior plaque. But again, would any of you would have thought of using a vitrector earlier on, or used it exactly when Dr. Arun used it?
I think, Chitra, I think it was an excellent case presentation, Arun. I mean, just when we were beginning to think that we should now use a intravitreal scissors, he did it. Just when we were beginning to think he should now use a vitrector, he did it. Just, you know, it was just going like a textbook, like picture in such a tough case. I thought it was very well managed.
Thank you, Dr. Namrata.
Yes, Arun. I also felt entirely the same, but I had to run a discussion. We can't close it.
Yeah, absolutely.
I think Arun has got 10 out of 10 because I also thought he managed it perfectly as I would have thought I would like to manage it. You know?
Thank you, Gaurav.
Arun, excellent surgery. Just a couple of points. You know, whenever you have this posterior capsular fibrosis, we have to differentiate whether it's a fibrotic capsule or whether it's a plaque. And if it's a capsular fibrosis, most often you cannot separate it and you have to do deal with it to get a clear optical access. Yeah. But in a case like this, obviously, as all others said, you did it beautifully and finally the results were good. But this was a plaque, and instead of you started dissecting it out from the 6 o'clock where you don't have access, I would have started my dissection subincisionally. And if I could have got a plane of cleavage, I would have injected cohesive viscoelastic in that space. I mean, ultimate result might have been exactly what you ended up with. But to get a plane of cleavage and get that plaque separated, and most often I've seen quite a few videos, and I've also done it in my own hands. These plaques, most often you're able to get a plane of cleavage and separate it. And cohesive viscoelastic injection helps in these cases. The PCR might occur. And one last thing I would like to say more for the sake of the viewers is that I felt that there was a slight peaking of the pupil right in the end. Most often you would find that is because of vitreous stand over there. Whenever I find something like that, I don't even mind going back in again with a injection of a triamcinolone acetate. You would often find that there's a stand of vitreous over there and take care of it right then and there. Otherwise, beautifully done, and I think all take-home points are there.
Thank you, Dr. Ramamurthy. I really appreciate that. It was very difficult in this case to get a cleavage plane between the plaque and the posterior capsule. I tried from all the planes, but I was not able to get a cleavage plane. Regarding the peaking of the pupil was peaked, as if you can appreciate, once I show you the original picture when we had just started the surgery, the pupil was adherent there. Because of the injury, the pupil was slightly D-shaped. So that was the reason for the peaking of the pupil.
Perfect. You used the tricot right in the end, and you did do a check. I mean, I just felt this was just a point we need to keep in mind. I'm sure you did.
Just a point, Dr. Chitra. I think what he has, Dr. Arun has said, rightly said, as Dr. Ramamurthy was saying, that you get a cleavage plane and you try to get it. But what he said was right, that when he was trying to dissect that, at that point he saw that there was a zonular pull. And that was, at that point, the zonular traction, he decided to go in with the vitret. I mean, we also come across this case. But when we see that the plaque, the differentiation between the plaque and the posterior capsular thickening is very, borderline. So at that point of time, you realize that I'm pulling too much on these zonules. I think the right decision going in with the vitrectomy.
And I think the most important take-home message in this whole video was that when his plaque was lying free and the tendency would have been just to pull it out, he stopped when he found that the vitreous was attached to it, went ahead with the anterior vitrectomy, freed it up, and then only withdrew it. Otherwise, there would have been considerable traction. I think that's a very important message for all the viewers.
Thank you.
Wonderful video, Dr. Arun.
Thank you.
Didn't discuss anything at all.
We'll move on to our next speaker now, Dr. Harshul Tuck. It's an absolute honor and privilege to introduce him. In short, if I had to say, I would say just what an amazing human being he is. But it's customary to introduce the scientific introduction. So Dr. Harshul Tuck is an admirable, innovative surgeon. He's a senior consultant from Marudhar Hospital, Jotwara, Jaipur. And he is my co-member, Academic and Research Committee, AIOS, from Central Zone. And we'll be looking at his pearl tip today. A very warm welcome to you, Dr. Harshul Tuck.
Thank you so much, Dr. Satyajit, for kind introduction. It's a great honor to be on ARC panel. So I'll be sharing a case of a mature cataract which had a fibrotic anterior capsule. Can you see my screen, ma'am?
Yes, yes.
Yes, we can see.
Okay. So this was a 70-year-old male patient who had, as you can see, a brown-black cataract and very fibrotic anterior capsule. So this case is being done under topical anesthesia. So after creating a side put incision and putting intracameral lignocaine, I stained the anterior capsule with Japan blue. And you see it was very difficult to initiate the capsular axis. And this entire mid-peripheral area was fibrotic. So I start making a small capsular axis with the capsular axis forceps. Now, why I wanted to make a small capsular axis in the first place was I wanted to check in which areas the fibrosis, it's fibrotic. So I see that it's fibrotic in almost all the places apart except from side port, between area of side port to the main port, because I may need to do some freehand capsular axis in that area because you can't put scissors there. So remember that these fibrotic anterior capsule, you need to cut with the micro scissors. So I go ahead and give a snip with the micro scissors, again put OVD. And from the side port, I, with the micro capsular axis forceps, I give a counter traction and hold this capsular axis edge, lift it up, and from another side port, I cut this fibrotic area. So I move on till I can cut from this side port. Now it's difficult to cut from this side port. So I make another paracentesis on the nasal side as I need to put the scissors in the right direction. And now in this area, there was a less of fibrosis. So I cut it till I can cut from this. Now with the dialer, I try to free up this subcapsular area from the bands because I need to do now freehand the capsular axis in this area. So once I free from this, see the direction of the tear. It's always toward the center. Flatten the capsule, hold it and pull it towards the center, and you can see the tear going in the right direction because in this area there is no fibrosis. So again, I change my hands give counter traction with microcapsulexis forceps, use the micro scissors, and I get a capsulorhexis which is of adequate size to take out this brown nucleus. Now, the vertical or horizontal chopping technique is always better in these kind of cases, as zonules are also weak here. So this is the technique what I described as drill and chop. I drill in the center to weaken the central endonuclear core. And once I drill in the center, then I go ahead and hold this piece nicely in the deeper plane and chop it with a sharp this chopper. And you can see I splitted it in anterior posterior direction completely. And once I get these multiple pieces, I take them out one by one. So this is the last nuclear piece which is being taken out, and we have the capsular bag which is empty now. So as zonules are always weak, so always maintain the antechamber before you come out. And we should be careful while doing irrigation aspiration that we don't pull on the fibrotic area or the so that zonules don't come. I do some polishing beneath the anterior capsule. And this is the hydroimplantation technique. Put the irrigation cannula in the anterior chamber, and the IOL is implanted in the capsular bag. And hydro stitch is done, and this completes the case. So I think if you are careful enough, you can easily handle these kind of difficult cases even under topical anesthesia without creating any complications.
Harshal,
thank you very much.
Harshal, amazing case, amazing. You did a wonderful surgery. What an amazing surgeon you are. My primary question is, you saw so much of this capsule thing, and then it was a grade 5 cataract. Never thought of SICS?
No.
Why was it so important that you had to do phaco in this case? Or for the general ophthalmologist, for everybody, I want to know that would you want to suggest SICS, or you would suggest phaco?
I think it depends from surgeon to surgeon. Like whatever you are comfortable with, I think you should go ahead with that. If you are not comfortable with topical, I think even many would like to put peribulbar block in these kind of cases. So I think it depends on your level of comfort. So, but what I feel is that if you look at long term, if you use like Viscoat and all the newer machines, the results of phaco are of course far more better than the small incision cataract surgery.
Sure. Yes.
Yeah.
That was a very wonderful surgery, Harshal. Again, a case where you did it very well and made it appear a lot more easier than how it actually is. But just for the sake of discussion, if these were fibrotic calcified cataracts, I think those are the places where you would think of using a vitrector to get an opening and then go on to create the rhexis.
Ma'am, if I'm not able to initiate the capsulorhexis with cystitome or with MVR blade or something, then next step what I use is the radio frequency dithermy probe. In Artley phaco machine, we have the radio frequency probes which easily cuts through fibrotic capsule. So in those difficult fibrotic, like this fibrosis was in the mid periphery where the capsulorhexis edge was there. If it would have been in the center or somewhere like I was not able to initiate, I use that. And if not that, then only I go to use the vitrector.
Anybody?
There was a ring of fibrotic,
yes,
ring of fibrotic ring. I mean, I would be tempted to, after putting the IOL, of course, remove that also, because that's the only thing which was a little pacified. And just to answer Satyajit's question, I think it is very important. Like for me to do SICS is difficult, and so I would go in for phaco. So I think it depends on what you are comfortable with. True, especially in this case. because there's so much of dense adhesion between the fibrotic capsule and the underlying nucleus, it remains to be seen that if you had actually done a rhexis and tried to deliver, and if there were some other areas of, similar adherence which are not visible to you, then SICS may have become difficult in such cases. Although I have no experience, so I don't think I'm the proper person, but that is what I would think.
Was it I want to hear from you what you would have done in this case and the previous one where you were asking me whether I would do FACO or SICS. What's your thought like on this case and the previous one? Would you have done FACO or SICS?
Whom are you asking?
Whom are you asking?
I'm asking Satyajit because he's been pestering us with the SICS versus FACO.
I've been coming around too much with SICS.
Both the cases, what would you
tell me your question again?
On both the cases like this one and the previous one where the post vitrectomy or post injection where you were talking about this thing, or even the posterior polar one.
I would definitely go with phacoemulsification. These are routine cases. We do phacoemulsification every day in these cases. But because we are catering to a large ophthalmologist around the message to be going around so that everybody who does see a capsular tag like this and a grade 5 cataract says I have to do phaco in this, that should not be the take-home message. Like Harshul said, you have to take your own call and decide if you are comfortable doing phaco, good, but you should also keep SICS in mind. For all these cases, we are regularly doing phacoemulsification, but I want it to be the message to go for everybody's benefit.
You're absolutely right.
I think when you're faced with a difficult situation, you should do what you're most comfortable with.
Correct.
As if you're regularly doing SICS and when you see a grade 5 cataract, you do a phaco or the other way around. So obviously, most of the panelists here are more proficient phaco surgeons, so maybe this is the answer you will get. But obviously, there is a forum where people would do SICS and get equally excellent results. These are just depends on the surgeon entirely. Harshul, for you, the kind of fibrosis that was there, is it a traumatic cataract? Or it's
No. It was not a traumatic cataract. Yeah.
I really loved the way you completed the rhexis, making the side port incisions, having access, and the absolute fantastic control that you had. But apart from the beautiful video that you saw now, I'd also refer the audience to a couple of videos posted by Dr. Deepak Megor and YouTube. He talks about the anterior capsular fibrosis, just like we talked about the posterior capsular fibrosis being different. There can be plaques under the anterior capsule, which can be separated and teased out, in which case the making of the capsular rhexis becomes fairly routine. The other situation where the capsule itself is fibrosed, in which case you might even have to use a vitrector to create an opening to access the nucleus. And these are concepts which you understand only when you see that video. But I found it very educative, so I just trying to add that point. But otherwise, wonderfully managed. And the other point is that as far as the brown nuclear cataracts are concerned, especially in traumatic cataracts, of course, you said your patient was 70-year-old, but some young patients, I find that the cataract is absolutely brown, but then it's soft also. It's almost, I call them the chocolate cataracts, where you expect a hard nucleus, but you end up, even though the color is brown, the nucleus comes out quite easily. And they're eminently choppable, or they almost come out like soft cataracts.
Gaurav, the theme of this session is top pearls in cataract surgery, not top pearls in phaco surgery.
But just one last point I want to add, ma'am, that one should never try to pull the fibrotic plaque, because that may cause the rhexis to rip off uncontrollably towards the equator. So you should always cut through fibrotic plaque, and wherever you see the clear area, there you can try to pull it. Yeah.
Thank you very much, Harshul. Great video. Our next one is Dr. Subhash Prasad, who's the Director and Chief Consultant of the Divya Drishti Eye Center, Patna. And he has another challenging, similar video to show, and I think we can take our discussions further on after his case. On to you, Dr. Subhash.
Thank you, madam. My video is again on, am I visible?
Yes.
Yeah.
You need to show.
I can't see your screen though.
Screen is not seen.
No, you are, I think, first you have opened your presentation.
Yeah, I have
and
opened.
you see the share screen green button below.
Sunil ji, help you.
On the Zoom window.
Mr. Sunil,
Yes.
you'll have to.
Yeah, is it visible now?
Yes, it has come.
Yeah. So we all know that capsulorhexis is the critical step of doing phacoemulsification surgery, and all of us are so expert in doing in every cases. But sometimes it's very difficult, like in anterior capsular fibrosis, which was just discussed by Dr. Arsul. In these cases, we are not able to achieve a round circular capsulorhexis, particularly in Morganian cataract, some traumatic cataract, and sometimes pediatric cataract. And there are various options, but in my opinion, vitrectomy cutter is one which gives almost 100% success and which comes with no extra cost. When there is just central anterior capsular fibrosis, you can do it very well with your routine methods of using the cystitome and then using the forceps, and you can very well do the capsulorhexis in this case. Like here in this case, is very central located. But in situation where there is a large, big subcapsular fibrosis, anterior capsular fibrosis like here, which has got a big pseudopodia-like extension everywhere, it's very difficult to achieve. And when I tried to peel the anterior capsule, it was coming in a piecemeal. So I used multiple times forceps and then cystitome to move from this side to that side, but ultimately was not coming out completely. So I used the Vanna's seizure to cut the extensions of the subcapsular fibrosis. But I again feel that using the vitreous cutter like Arsul talk has shown would have been a much better option. And this is video which I just want to highlight here, that what the mistake I did here should not be done by anyone, because here I'm going from one side and it's likely to extend to the periphery. But from the other side, I'm using the Vanna's just to complete it. And even though it's not say a circular round capsular exercise, I did the good phaco in this patient, and ultimately I achieved a good result. The another case which I just wanted to show is a hypermature Morganian kind of cataract. Again, you can see a big, large subcapsular fibrosis. Here again, I am using the Vanna's seizure and the cystitome. And once I achieve a round, nearly round circular opening in the anterior capsule, I thought that probably I can go below the anterior subcapsular fibrosis and do the phaco, but I was mistaken, and the part of the anterior subcapsular fibrosis was coming on the way. So I tried to cut it with the Vanna's seizure, but it did not work. So I thought of using the cutter here, and with the same machine cutter, I used 23 gauge vitreous cutter I used here to make an opening in the subcapsular fibrosis all around, and which was able to give a nearly circular central opening in the anterior capsule, and then it was possible to manage this case with equal ease like in other cases. One thing is very important, that whenever you tackle such cases, always stain the capsule, because it truly delineates the fibrosis and other part. Another use is in the congenital cataract. You see the nucleus, whole cataract is moving actually when I'm trying to do the capsulorhexis. So in this case, I thought to use the vitreous cutter. But to use that, you have to have one opening, central opening, or any opening in the anterior capsule. So I'm using the MBR blade, because it's not possible to puncture the anterior capsule with the 26 gauge needle. Then I started using the cutter, changing the hand from left to right side with the side port incision only. I was able to do it. The advantage of the cutter is that you can cut the anterior capsule. You can aspirate the cortex. You can do the posterior capsulotomy at the same time. You can do the limited anterior vitrectomy. So it serves all the purpose in a congenital cataract. And with the cutter, you can see that I was able to achieve a round opening in the anterior capsule, which was sufficient enough to handle the cataract in this patient, since it was just 4 months old baby. So I did not put intraocular lens here, using the IA mode to aspirate the cortex and in between changing. So this was all in from my side. Thank you very much. And I feel that when you have difficulty in these cases, cutter comes very handy, because all the machines have their attachment there nowadays.
Thank you very much, Dr. Subhash. Wonderful videos. Lot of learning came through it. Actually, as Dr. Ramurthy was trying to explain earlier on, there were 2 of your cases which had a lot of subcapsular plaque. So experience tells that you need to tease out these subcapsular plaques, and then you're able to fashion out your excess better, as against a fibrotic capsules where you have shown how you have used a vitrectomy cutter. when you talk of vitrectomy cutter, I would like to know what would be your settings.
Like in other cases, I use it 2000 cut per minute, and then the aspiration of around vacuum of around 200 millimeter. Here in this case, it was set to 4,000 actually. We have the option of changing in the Centurion from right from 2000 to 4,000. So
Any thing?
I just wanted to say that vitrectorexis has been classically described earlier for a posterior capsulorhexis, and has also shown that the margin that you get by doing using a vitrectomy probe vis-a-vis the one that you do manually, there is a difference. Although clinically, I'm sure, Subhash, it doesn't make too much of a difference, but submicroscopically there is a difference that it is weaker than the margin of a normal capsulorhexis which you do it by hand. Just like by femto it doesn't make a difference, although microscopically there'll be a difference. But I also thought as much that subcapsular fibrosis is the one which has to be dealt later, and then there is a fibrotic thing which is there over the capsule which has to be peeled out or dissected out first. So when you're using the cutter immediately, you probably will not, do it layer by layer. But if you're using other instruments, then you would probably do it layer by layer.
Just for the sake of completion, we all keep talking about the role of femtosecond lasers in intumescent cataracts, swollen cataracts. But even in these fibrotic capsules, it's of a great help. Most often, you don't end up getting a free-floating rhexis. Usually, in these situations, I increase my offset for the anterior capsule from 300 to 500 microns, both anteriorly and posteriorly, and also increase the spotline separation. Decrease the spotline separation so that more energy goes in. And usually what you get is a template. And in these cases, stabilizing the eyeball with Sinski hook through one side port, I go in with a bent 26 gauge needle. And that template which has been created with a femtosecond laser allows you to create a rhexis. And of course, in extreme fibrosis, sometimes the femtosecond laser doesn't work at all. But in many of these fibrotic anterior capsules, it's a great help to do the rhexis with a femtosecond laser. The second point I wanted to make was the settings for the vitrectomy settings that you mentioned about. The high cut rate of 4,000 is something that we use for anterior vitrectomy because those are vitreous strands and you don't really need too much energy. But these recalcitrant fibrotic bands require a lot of energy to be cut, a lot of force to be cut. In these cases, I would decrease my cut rate to 500 to 600 and also increase my aspiration rate so that, these things get dragged into the port of the vitreous and then go ahead and cut it quite adequately. If you use an extremely high cut rate and if it's a very fibrotic band, these bands may not get cut. That's the reason that in soft vitreous, you use an extremely high cut rate and you don't want to drag any vitreous into the port.
Okay.
Both for the iris and for the fibrotic capsule, your cut rates have to go down.
Yeah.
As opposed to what you would do for anterior vitrectomy, because otherwise it doesn't come into the port. It's too fast to come into the port. So your cutting rate should go down.
Use the cut IA mode. I think the cut IA mode, cut and then.
So then you would say, you can conclude saying that you keep it at around as something like 500, 600 as a cut rate, and you would use your
and use IA cut mode rather than cut IA mode.
Yeah, because it has to be dragged into the port and cut.
Our next speaker is Dr. Kiranjit Singh, consultant ophthalmic surgeon, specializing in cataract, glaucoma, and is a brilliant and innovative surgeon from Amritsar. And he has a lot of learning tips for us in his cases. On to you, Dr. Kiranjit. He was here all along. Dr. Kiranjit? Yeah.
Is he on mute?
Okay, Kiranjit, please unmute yourself. Sir, we can't hear you.
Dr. Kiranjit, can you unmute yourself?
Yeah, I have done it. Okay. So, is it okay? Is it okay now?
Yes.
No, it has again gone back. Yeah, now it is okay.
Now it's okay.
So I have to talk about overrexes. Its safety in posterior polar cataract and very hard cataracts. Usually the complications we encounter are mainly in posterior polar and very hard cataracts, but I don't get any complications by the grace of God. And I have to show you this. This is how it looks like, the overrexes. Larger rexes aids in easy removal of nuclear segments, whereas shorter axis helps in strong optic capture. So we published a paper in 2011. This is overrexes being done by Kamal Kapoor. He says hemi segments come out without any rotational movement in posterior polar cataract. Dr. Rohit Om Prakash says the same. He does overrexes in PPC and pre-existing ruptures. And Dr. Deepak Mugar has started doing overrexes in very hard cataract. And he says it helps in easy division because he can make long and deep cutters. So to start with, I'm going to show you a case of PPC with a PC rupture. Staining the interior capsule is a good thing. And with overrexes, you can make long gutters, and you can actually chop the segments inside the capsular bag, or you can take out the whole heminucleus into the interior chamber because of the larger axis of the overrexes. So you can pull it out without any rotational effect on the PPC. So once the main cataract is gone, you have to utilize the services of irrigation aspiration cannula. And when you have to withdraw the tip, you have to inject some viscoelastic. And when you have a conical tear extending up to the periphery into the zonules, which you can see here, you can actually convert that into a PPC. If it is broad, then you don't dare to do anything. No, it is conical, you bring it back, it become a continuous thing on one side. And when you are done with this, you inflate the capsular bag, and you can put the lens in the capsular bag itself instead of putting in the ciliary sulcus. So it opens up flat. If it is a small axis, the lens may open up tilted and it may go into the vitreous. So this is another case in which I did an anterior and posterior overrexes and put the lens in the capsular bag. Staining in the interior capsule is a very intelligent thing, which everybody should do. So in this case, the hydrodelineation was not very accurate and maybe the cause of tear in the posterior capsule. So what you see is that impression of the PPC on the interior vitreous face is still there. That round thing is still there. And you see that conical thing, you pull it back, it becomes a continuous thing. And from this side on also, I push it down and it becomes a continuous thing. Now I have a space, I have two oval rexi in which I am going to implant the lens. Had it been a small rexis, it would have been difficult to control the opening of the lens while unfolding. So the lens goes in the capsular bag. So coming on to a hard cataract, this is a 90-year-old man with a grade 4 to 5 cataract. And when I do a oval rexes, it gives me a chance to make very long and deep cutters, which are very easy to break. And I am using a blunt needle because of, I don't know what was the reason. My assistant gave me a blunt needle, but still I could manage cutting the nucleus. And you see, this point is very important. This Dr. Mahipal told me in 1996 while he was doing live surgery in Kanpur. He told me the cleavage line should cross the midline. That is very important. A single thread attached to the other side will not let you take out the now the segments are debulked, and the debulked segments are small. When you take them out, less chances of injuring the endothelium. And number two, keep the Sinski hook or the chopper over the segments so that the endothelium is not injured. So I go to the next case. So that is the rexes. So it become grade 4 cataract behaves like a grade 2 cataract. So this is a movie just to show you that somebody may say that that narrow axis may cause cosmetic problems. So for that, once you are done with your phacoemulsification, give a snip on both sides of the capsular axis and make it larger axis, which is not possible when the cataract is there because it may go towards the periphery. So once you're done with the phacoemulsification part, you give a very nick on the both sides, make it very big, put the lens in the bag, and believe me, a bigger anterior axis will never give you a PCO. So the lens in the back. Thank you very much.
Thank you very much, Dr. Kiranjit. You showed a wonderful range of videos wherein it comes across very clear to us that if you're using an oval rexus, you have the great advantage of doing an end-to-end sculpting and fragmentation and in challenging polar cataracts. And also when you're doing a vitrectomy also, there's no great stretch, and the smaller diameter of that oval rexus will allow an optic capture. So all these things came well across. Why is it you did not show the case of microcornea, which you...
That is in my another video. I can show it.
No.
Okay,
because, I felt that that would have evoked a lot of discussion, which was not being discussed here. Anyway, so I wanted the expert panel to give their thoughts in these different situations which you showed us.
Sir, I have a question, sir. This oval rexis for premium IOLs long term is centering an issue. Have you had any study on that?
No. If the patient needs a premium IOL, then I go with the round rexis. I don't go for oval in every case. It is only in hard cataract and polar cataracts. Otherwise, I am.
If a patient wants a EDOF lens or wants a panoptics kind of a lens or wants a, then what would you do?
PPC, especially the PPC.
We'll do a central rexis, circular rexis.
Yeah. Then I'll go for a central rexis. But if it is a posterior polar cataract or a hard cataract, I'm not going to do a small rexis because small rexis is going to cause so many problems. So I may convince the patient not to go for a premium IOL, simple I will go for it, but I will not take chances, I think.
I have another question for you, and that is in your cases that you showed, your posterior polar tear was along the axis of the ovality of the rexis.
Yeah.
What if it is perpendicular? Because sometimes you tend to have, those horizontal tears and your oval is on the other side.
Yeah.
So you are kind of creating then disproportionate forces on the anterior and the posterior capsule. Then, I mean, what would you do in those cases?
So if I have a tear which is perpendicular to the oval rexis, I will use Haldi-Purkar forceps from the side stabs. And if they have not gone into the equator, into the deep equator, I will still pull them with the help of Haldi-Purkar forceps and still try to make a PCC.
Just a point, Dr. Chitra. I think in the earlier video where you have got a PPC rupture, putting a single piece lens, and even here also, it's very important to note not all single piece lenses go in so smoothly as you have seen. It could be the Rayner design or even the Technis, or we have seen the IQ. I have no financial interest, but the way the IQ lens opens so easily, maneuvering it in the bag with the PC rupture is definitely much easier than all the other, the Gamma. We have the Envista, we have the Rayner model, we have the Technis. I have found it's easier, though I use all the design lens. But as he has said, that I think he has shown both the lenses were IQ lenses where it opens up just like a baby, and then you can gradually manipulate it and put it in the remnant of the capsule and just half open bag. That's just a point to manage. It's not all single piece lenses that you can put in.
Very nice concept, Dr. Kiranji, then very nicely explained.
Thank you, sir.
I think truly a take-home message. I would like go further ahead and say that in every case, I think the long axis of the capsular axis that you do towards the 6 o'clock, obviously if it's a temporal clear corneal, it's towards the nasally, it should be somewhat away, because most of the chopping happens over there. And that's, if you have the rexis slightly shorter in that axis, you end up damaging the margin of the rexis. So I'm extra careful to make sure that the rexis goes a little further away in straight opposite to where my incision is, which is in the temporal clear corneal area. But in some of the videos that you showed, and as was being alluded to by Namrata and others, the rexis seem to be extending almost to the margin of a fully dilated pupil, almost to 7 millimeters.
Yeah.
In these cases, obviously, as we know, posterior capsular opacification, other things would be a factor. So even in these hard cases of hard cataract, PPC, I think I would stick to my 5.5 millimeter, make sure that it's not shorter than that, but I'm able to effectively handle it, because the lens subsequently requires that there is a regular overlap of the rexis margin onto the optics.
Yes, very true. I do also believe that we need to have that rexis overlap. So except in a very hard cataract where you are able to show a very safe surgery and a very old patient, maybe it was not to jeopardize the steps of the surgery. I think we need to keep in view that it doesn't get so oval that it compromises on the PCO. And there's another wonderful thing Dr. Kiranji showed was, like, if you have a PC rent, how you could actually unfold the IOL not into the bag, over the bag, and then gently tuck it into the bag so that the area of the tear does not increase. So there have been wonderful learning tips from your case.
I would like to have a response from him. I mean, your incidence of PCO with this oval rexis, I mean, I thought you were about to say something.
Oh, so the thing is, if you have a PPC with a rent, then you are not going to have a PCO also, because there is no posterior capsule over there. And in a 100-year-old man or a 90-year-old man, even if he gets a PCO, there is nothing. You can have a laser, you can laser it. But what we worry is that we should not drop the nucleus or rupture the posterior capsule and put pressure on our own heart. That is the things we should take care of. And laser is always available. And with a CCC overlap on a very premium IOL, you can still get a grade 3 PCO. Even with Acrysof IQ and this Alcon lenses, you can still have a PCO. So PCO can come anywhere in any of the lenses, with the oval rexes or with the round rexes, and you can laser it. Basically, oval rexes is for risky cases, not for normal cases.
Good. Thank you, Dr. Kiranjit. Wonderful videos.
Thank you, ma'am.
I'll now go on to our next speaker, Dr. Neeraj Kungar, who's the Medical Director of Ajmer CFS Group of Hospitals, who is again going to tell us something very relevant and a learning video. We look forward to hearing from you, Dr. Neeraj.
A very good afternoon to all of you. Thank you, ma'am, for giving me this opportunity. I'll be talking on capsular axis in intumescent cataract. Are you getting me?
No.
Dr. Neeraj, we can't see your video.
No, we can hear you, Neeraj, but...
Okay, I'm just sharing my screen. Okay, so the aim here is to avoid Argentinian flag sign. So there are various ways. We'll just go through few techniques. One is the conventional capsular axis. Here we just make a small nick in the anterior capsule and wait for the milky fluid to escape, because it is the fluid which is causing increased intralenticular pressure. So to decrease this intralenticular pressure, which is dangerous and which is the root cause for Argentinian flag sign, we need to decrease this intralenticular pressure and let the fluid escape. Then again we replenish the visco, and then we make a smaller rexis initially. I am doing it from the main port, but we can have a much better control if we go through the side port, or we can make a graded incision, main port incision, that is we can increase it later. So, but this is basically a two-step procedure. One is you make a smaller axis, do your phaco, and then you increase the axis size after implanting the IOL. So thus you can achieve this good capsular axis. The second technique that I use is phaco-capsulotomy. Here the settings are phaco only, torsional 80%, fixed, vacuum 150, flow rate 28, and enter at position 0 after injecting a higher order visco. Another point is that we should always use a higher order visco. You can see the moment I go to the foot position 3, there is a sudden flattening. You can you can see the fluid is sucked in the phaco probe, and there is a sudden flattening of the anterior capsule. The pressure is gone and the fluid is gone, and now we can make a capsular axis very comfortably. No need to enlarge it later, because here there is no intralenticular pressure and we can easily make it. Another clipping again shows, you can see there is a sudden flattening of the anterior capsule. So this is the second way that I usually do. Another case here, I use this technique, suck and massage technique. This is another technique that I have been using, where the pressure is very high. We cannot go in with the phaco probe here, because here if we go in with a phaco probe, there are chances that the capsule will rupture. We make a very small nick here, and from this small nick we just come out again and we replenish visco and reposit the iris. And now we suck the fluid from the center, from the small nick that we have made. And after we suck the fluid, there is some amount of decrease in the intralenticular pressure, but still you can feel that there is a mid-peripheral bulge. So it is the key point here is that it is the mid-peripheral bulge. So we need to remove this fluid from the mid-peripheral bulge, and this I do, we gently massage it and keep on injecting the viscoelastic and massage it to the center. The fluid will automatically come from the periphery. The mid-peripheral bulge is gone, and once the mid-peripheral bulge is gone, as you all must be aware if you have faced with this dilemma, it is the mid-peripheral bulge which is the most important and which is the most troubling to us. And the fourth technique is that we just go with the 26 gauge needle bevel down and just aspirate the fluid. You can see that the fluid is being aspirated, but again there is a mid-peripheral bulge which again needs to be massaged. So these are the few techniques that I have shown you. And apart from this, as I said in the beginning, it is better to go from the side port or make a graded incision. But as I have been doing it since ages and I am doing from the main port, I have shown my video from the main port, and always use a higher order viscoelastic. Thank you.
Thank you very much, Dr. Niril. Wonderful videos, different types of management you brought across. One doubt I had when you did that puncturexes, I thought you need to take your bevel down and go in. I felt your bevel was up. Does it make any difference going down or using the bevel up? Is one
with the Kelman tip and with the torsional phaco, I prefer to go with the bevel up.
Okay.
That is how this, like in my hands, it works very well. If you have a straight tip, maybe then you can go with bevel down.
And of course, I think like most of us do, I believe that you try to make a small rexus and then remove all the fluid, flatten it, and then enlarge it or make a small nick. I have not heard of this massaging the mid-periphery. I thought that bulge, we should remove all that fluid cortex by going in after a small opening. That was something I've not heard about. I needed the thoughts of the expert panel on that. And the third thing, this is not being shown, but even though I have not done, I remember seeing some videos. What do you feel in these intumescent cataract if you do multiple can opener incisions diametrically opposite? I'm sure the traction forces will work such a way that it does not extend. Would you think that could also be tried out in these intumescent cataract, and then you use your forceps to carry on with the flap and complete it? Just a thought whether that could also be done in some of...
I have never done that before, but any radial incision, there are high chances of it running to the periphery.
No, if it is just
So,
one, if there are multiple. Actually, that was one video I saw in some of the earlier presentation. So I just wanted your, that wasn't.
I have never done that. I have been always.
Ma'am, I have a.
Madam, this is Dr. Bala here.
Yeah. Yes.
I think my next video demonstrates that.
Okay, 1 minute. I wanted to ask Dr. Namrata Sharma, ma'am, for the benefit of all the ophthalmologists, general ophthalmologists, when you look at a case of an intumescent cataract, with your experience, can you predict that there's a high probability that in this case, Argentinian flag will happen no matter how careful you are?
Yes, I would say for Namrata answers is that if I have an access to an anterior segment OCT and there are fluid pockets are there, those fluid pockets could be released, and in those cases you could actually get away with a good round rexus. But only in those cases where it's swollen lens matter, which is a jelly-like, in those cases you could get a rip. I would want
Namrata, ma'am.
Chitra has very beautifully, I think, explained it. If I do have an anterior segment OCT and if intraop OCT microscope is there, it doesn't matter whichever you have, and you can see those dark areas in between, which are fluid-filled spaces, then you know it will probably not go into extension. But if it's completely, blacked out kind of a picture which has no spaces at all, then it would probably go. In the slit lamp, you can make out, because if it's a completely white cataract, again, sometimes you can make out that it is full of fluid, especially in children, in pediatric cataracts. There you can make out, and then you know it will go into Argentinian, flap. I really like the maneuver which Dr. Neeraj showed, although I have not done myself and I have not seen the massaging part. And I think it has a logic to it now because you can now, compare it with your AIOS-OCT feedback pictures also. So, and it looked good on the videos, although we've not been doing it. We just, aspirate the fluid out without massaging it. But I think it makes really sense to do it. Nice videos, Neeraj. Very nice.
Thank you. Thank you. One more thing I like to add, just to complete the literature. One of my friends has devised a technique. He's doing YAG capsulotomy, like just before the OT. He makes a small opening in the anterior capsule. And by the time the patient is shifted to the OT, the fluid escapes from there and the intralenticular pressure is decreased. But here the timing is very important. You cannot wait for a longer time. Otherwise, there'll be problem.
Okay, thank you. So we are going to go on to the next case of Dr. Balasubramaniam because it is a similar case. So I put them together. So Dr. Satyajit, could you introduce him?
Our next speaker is Dr. Balasubramaniam, yet another prolific surgeon. Dr. Balasubramaniam is the medical director and consultant ophthalmologist of Achyuta Institute of Optometry, and we'll be seeing his brilliant pearl today. Dr. Balasubramaniam, a very warm welcome to you. Sir, you are muted.
Am I audible?
Yes, now you are, and we can see your slide also.
Yeah, I think Dr. Chitra Madam has set the tone by arranging the videos. My topic is also on doing capsular rexus in intumescent cataract. So what I do is what we call a 3-stage capsulotomy in intumescent cataract. So as you all know, in intumescent cataract, intralenticular pressure is the main reason for the risk of Argentinian flag sign and peripheral rexus extension. So this video basically demonstrates a safe technique of performing rexus in intumescent cataract. So the first stage, as we had this discussion, instead of making a horizontal neck, one needs to make a central can opener. So when you make an horizontal neck, the problem here is you have 2 weak points. And when there is an increased intralenticular pressure, it is going to exert the pressure only on those 2 points, and naturally it is going to extend and go to the periphery and cause the Argentinian flag sign. So how can one avoid this? Because in however small nick you make, you need to make a nick to raise the flap. So however small nick you make, if the increased pressure is so much that it will definitely extend to the periphery. One way of avoiding this is making instead of 2 points, making multiple puncture points in the center. The rationale behind this is the intralenticular force is distributed to all these points so that none of these points extend to the periphery. And I've been doing it for many years and not even one single Argentine flag sign, because I'm a cricketer, you don't want to have a golden duck. So you don't want to get, as soon as you puncture Argentine flag sign. Once there's no Argentine flag sign, okay, now you gain the confidence. So this is how I make the initial puncture. So I never make an horizontal nick. The key here is you don't go to the mid-periphery. You make it close to the center. Paracentral multiple punctures, similar to how you make a can opener on an ECC from the periphery to the center. I mean, paracentral to the center. As you make the puncture, you can see that the puncture point is tending to extend, but if you make an adjacent puncture, then it stays like that. So all the interlenticular pressure is distributed to all these points. So you never need to worry about the Argentine flag sign, how much ever the interlenticular pressure be. This is another case with extreme interlenticular pressure. You can see the fluid milking out, coming up. So you make multiple punctures. I don't have anything to worry about the Argentine flag sign. So once you make a central opening, then the next step is the decompression of the lens. As my previous speaker has mentioned, I also do what is called the massaging from the periphery to the center. So you push the cortex from the periphery to the center. The key here is you have to massage from the periphery to the center. One can always do a needle aspiration at this stage. So here you don't need to worry about extension because of the multiple puncture points. Once an initial decompression is made, then the next step is convert the small can opener into a central capsular axis. The key take-home message or pearl here is make sure you include all the puncture points so that one gets a continuous curvilinear axis. If you don't include the puncture points within the axis, then there's always a risk of axis extension during a further manipulation. So you go all around the puncture points and then you get a good central axis. This is another case where a central can opener is made, initial decompression done, and then a small rexus is done going around all the puncture points. And once this is done, then it becomes a lot easier. We can go for the second stage of decompression, and this is done with irrigation and aspiration of the cortex. So you can go with the IA cannula or even with the syncope cannula and remove the cortex and debulk the lens. And once the second stage of decompression is done, then it behaves like a normal cataract, where the intralenticular pressure is normalized. Then you just make a nick and enlarge the rexus to the adequate size. So this is basically a three-stage capsulotomy: initial central can opener, then convert a small rexus, then enlarge the rexus. But of all these three the stages, the first stage is critical. That's what I feel, where if you make a multiple puncture instead of an horizontal nick to raise the flap, one can definitely eliminate the risk of Argentine flag sign. And this is a very safe technique and reproducible. You have seen needle aspiration, going with a phaco needle, all these things you will see videos, and along with these videos, there are cases where Argentine flag sign happens. But with this technique, there's no risk of Argentine flag sign, and one can perform a safe rexus in intermittent cataract. Thank you.
Thank you. You can stop sharing, Dr.
Yeah.
Thank you very much, Dr. Balasubramaniam. You showed us a different way to look at these intermittent cataract. I think I saw your video only and I didn't remember it was yours.
Okay, that's
The
fine.
scan opener thing was definitely a very, something which I have not done, and though I wouldn't mind trying it, because definitely if that could help, that's one other way of skinning the cat. So that was pretty good. And of course, I'm still unsure about the massage, though Dr. Namrata seemed to be, I'm somehow not clear how it actually helps. How massaging the mid-periphery, I would keep thinking that that means the sole, I should go and do more multiple hydros to flatten the lens capsule. How just a stroke on top would help beats me.
No. This basically you're milking, trying to get the cortex into the out of the bag. At this stage, if you do a multiple hydro, especially with once you make a central can opener and hydro, there is always a risk of extension.
I thought it was a very nice video, Dr. Balasubramaniam. Congratulations on that technique. And we used to say do a two-stage capsular X's in white cataract. So now you've added one more ring to it, and now it is a three-step capsular X's. The initial part looks very much akin to Panchorexes, except the fact that, and probably the concept is also the same, except that you're not doing it with phaco, but you're doing it with the needle and punching the central part. But I did think that in cases where those spoke-like things are there you're unlikely to get an extension or Argentinian flap, because that's not completely that's not a capsular bag which is completely full of fluid.
Okay.
So it would be, I don't know, I mean, you're saying you've not had, so obviously there would be no comparison to show that if you do 3-stage vis-a-vis 2-stage, whether it really happens or not. But I think it has to be tested, and I'm sure all of us here in the expert panel are going to go back and test it. And it's been the other way around. You've become our expert rather than we becoming your expert.
No. My message here is whether you do it as a 2-stage or 3-stage. The first stage, instead of making a horizontal neck, if you make the multiple can opener, you definitely eliminate arginine flaxine. And once you're confident there's not much interlenticular pressure, from that you can just make an adequate access rather than trying to do it twice. But the initial, I've seen a lot of videos where they try to make a small neck and then it zips. I've seen where they go on with the needle and try to aspirate the bevel edge on either side, makes a neck. And before, when they take the needle, it's gone to the periphery.
I think we'll have to go to our next talk because we have very few, not much time and many more speakers left. So we go on to our next speaker, Dr. Hemlata Gupta, who's a senior consultant from the Center for Sight Group of Hospitals, New Delhi, a brilliant surgeon with exceptional skills. And we are sure going to like her teaching pearl. On to you, Dr. Hemlata. Can you share your screen? Yes. Dr. Ravi, you would be the next, and then Tushya. I don't see Dr. Jay.
I think Dr. Jay was here.
There, okay.
I did see his.
Unmute yourself.
A very good evening to all of you. Can you hear me, ma'am?
Yes.
Yeah, Hemlata.
Thanks for having me here. So here is a case of subluxated cataract. This patient had post-traumatic subluxation of more than 180 degree with grade 3 nucleus crosses. So we decided to do femto laser cataract surgery for this patient, as we know that doing manual rexis is really difficult in these kind of patients because of the lack of zonal countertraction. So we are doing this on Catalyst platform where we have the option of custom centration and sizing. And the rexis is really fast in this with Catalyst. So I started the surgery under peribulbar anesthesia. When I injected the viscoelastic in AC, you can see that there's a sudden bulge prolapse of the vitreous through the side port. So here we put trocar into the pars plana area and limited dry vitrectomy was done to remove whatever vitreous was there in the area of zonular defect. So to enhance the vitreous strands, tripod was used. It was put through AC, and then vitrectomy was done. And once that was done, I'm removing the capsular already cut by the femto laser and making space for the CTR. And this is capsular tension ring being placed to stabilize the capsular bag. Now, once the capsular bag is stabilized with the ring, the removing or emulsifying the nuclear fragment is really easy because of the pre-fragmentation of the nucleus by femto laser. We just lift the pieces one by one and emulsify. And you can see that how deep the anterior chamber is. And we get the adequate working space and we are away from the endothelium. So this is all happening because of the dry vitrectomy that we have done earlier. So after removing the epinucleus, we proceed to removal of the cortical matter, which can be a little bit of difficult because of the pre-placement of capsular tension ring. So repeated shallowing of the AC is what makes surgery difficult. What happens is then when we do IA, because of the irrigation, there is fluid migration into the vitreous that leads to hydration of the vitreous, and that vitreous pushes the whole of the capsular apparatus interiorly. So the simple solution is remove the plug from the trocar. Like you can see, we have removed the plug from the trocar so that when you're doing IA, there is egress of the fluid from the trocar cannula itself, and repeated shallowing of the AC is prevented. And then we place 3-piece IOL safely inside the capsular bag. And in the end, a little bit of with more anterior vitrectomy is being done through pars plana area just to remove the residual vitreous stands from the area of zonal defect. We should not be doing over vitrectomy because that will lead to hypotony. And you can see a little strand of the vitreous is still there in the AC, which is removed with the help of cutter placed in the anterior chamber. So trocar is just simply taken out in the end without placing any sutures. And this is the day 1 picture with 6/9 vision, well-centered IOL and clear cornea. So limited dry vitrectomy, it actually prevents the repeated herniation of the vitreous into the anterior chamber and deepens the AC and gives us adequate working space. And that's all. Thank you so much.
Thank you, Hemlata. That was a very nice video. Can you stop sharing your screen?
Yeah, sure.
See, there are these 2 questions which I have, which Hemlata and the expert panel could answer. Now, traumatic cataract is what she said. So, assuming it was a non-progressive case, a CTR alone would have helped, though the area of dialysis was nearly 180. The other question is something which I actually have for all of us is, you know, we all know that removing the cortex is a bit of a challenge in the femto cases, femto cataract platform because of the vertical cutting of the fibers. But on top of it, when we put a CTR, I think that further adds to the challenge. I have never exactly thought too much about it, but what are your ways of dealing with a case of femto cataract with a CTR in place? And of course, what do you feel about just a CTR having been used in this case? Yes, Ajay.
Yeah, I would normally, what she has done, number 2 points, I would not put the trocar right in the beginning here because I don't know how much vitreous is there, because the trocar pushing in there, the fluid going in, whatever vitreous is there, more tendency to come forward. I'd rather do a vitrectomy from the anterior side, not taking out too much, because if you're trying to pull the vitreous, it goes on coming. If you're putting a trocar, then go behind in the pars plana, cut it. Only just putting a trocar, fluid coming in, more vitreous, tendency of vitreous to come in. Now, anyway, so once you have done that, now putting in the CTR, the point she had was, well, I would do first a visco dissection. I mean, instead of hydro dissection, a visco dissection, take out a plane of cleavage between the anterior rhexis margin and the cortical matter, and then try to push the CTR through that. Once you do that, I think most of the time the CTR would go just bisect the fornix area, and then you'd be having very little cortex which would be going around that CTR. So the removal would be easier in that case. And in this case, otherwise, it was very well done.
I think very nicely managed, Hemlata. The only thing I might have done differently is that not used a CTR in this place, but used a capsular hook. In the sense that, you know, it was a traumatic cataract, and though it was definitely subluxated, there seemed to be reasonable support for the capsular bag. And more than a circumferential support, I think it was an anterior-posterior support in the area of the dialysis that was needed. And that would have been served well by 1 or 2 capsular hooks, better than putting in an endocapsular ring. I would have definitely placed the endocapsular ring after the evacuation of the cortical material and before the implantation of the intraocular lens. But the lens back stabilization, especially now that you have an excellent rexis created where femto would have been much better with a capsular hook. And removal of the cortex and the epinucleus would have also been not a difficulty because the endocapsular ring is not there. The second concept is, of course, for ages we have been putting this three-piece lenses in the back with the orientation of the haptics in the area of the dialysis. But nowadays, I think more of us are shifting on to putting it in the sulcus with the haptics in the sulcus with the optic capture. And this is supposed to stabilize the bag much more than even putting it in the entire lens in the bag.
So
Yes.
the point,
I wanted to make a quick
point
comment.
I think here is to prevent the repeated vitreous herniation. You must have seen in many of the cases when you're proceeding with your phacoemulsification or IEA, again the vitreous comes out. So we can either put viscoelastic in that area to push the vitreous back. So in this case, we are not doing the putting the infusion cannula. It's a single trocar. We are just doing dry vitrectomy. Like Dr. Ajay said that that can lead to hydration of the vitreous, but we are not putting any infusion cannula. It is a dry vitrectomy just to deepen the anterior chamber and just sufficiently, I mean, just a limited amount of vitreous is removed. So what I feel is that has improved the surgery a lot in our experience.
Dr. Chitra, can I chip in with a quick comment? I just wanted to, everything is managed so beautifully and everything was done well. I just thought that at one point where we could have done something differently was that right at the beginning of the case, when you put viscoelastic from the side port, you chose to put it from the port, which was right where the subluxation was. So that actually ended up pushing the vitreous out of the other side port. Had you gone from the opposite side and pushed in viscoat, it would have...
Yeah, the problem is the subluxation was 180-degree temporal. So the other side is nose. So your side port
No, not the
in the
trocar.
area of funnel.
Not the trocar.
No,
I just
not the
meant
side
that you could
port.
have side port. You could have gone from the main port to put viscoelastic. It doesn't matter. I mean, you already all you had to do was choose to go from the opposite side, so that the vitreous was pushed back. And most of the times you don't have to do much, even if the vitreous is coming forward. If you use viscoat to fill the chamber, and then it just kind of pushes it back and it goes behind. Even if you can see on the slit lamp that there is some vitreous coming anteriorly, if you put viscoat, it'll push it back and it'll go back. It'll stay there. You can proceed with the surgery without doing a vitrectomy for most of the time. And when it starts coming back, you can again use viscoat again goes back. And you can do that 2-3 times, and you can actually sometimes get away without doing a vitrectomy and just putting a CTR in the end, and then it can be done. But if you use the viscoelastic from very close to where the subluxation is, it may actually push the vitreous towards the other ports, and that's why it might just come out from the other side.
And we also
I agree. The main port visco could have been put from the main port.
Otherwise, beautifully done.
And of course, the other important tip which Jay said, which we often do, but before placing a CTR, doing a visco dissection and then placing a CTR makes more sense. That was good, Dr. Jay. So, Satyajit, can you
move on to the next speaker, ma'am? Our next speaker is Dr. Ravi. He is the Medical Superintendent and Center Head of Tirupur branch of the Eye Foundation Group of Hospitals. And he will be sharing his pearl today. A very warm welcome to you, Dr. Ravi.
Thank you, Dr. Satyajit, for having me here.
Can you share your screen?
Can you see the screen?
Yes.
Yes, yes.
I'm going to speak today on, again, another technique of handling the immature cataract. I think both Dr. Neeraj and Dr. Balasubramaniam spoke about beautiful techniques to manage intumescent cataract. But luckily, they didn't mention about the technique which I'm going to speak today. As you all know, the most difficult and important step in this intumescent cataract is obtaining a good capsular rexis because of the tendency towards rexis extension and a wraparound capsular tear and the risk of nucleus drop. So the capsular rexis runoff or the Argentinian sign is common in intumescent cataracts, and because of the high intralenticular pressure, and it is imperative to prevent any chamber fluctuations in these cases. So performing a routine capsular rexis may be difficult in these situations. So I'll be showing a few videos which depict a simple and inexpensive technique called the cannula vacuum CCC. Here we just need a 25 gauge round cannula with a flat tip connected to a 5 cc syringe, which is half filled with a BSS solution. Now, this was advocated by Dr. Sirish Kumar, my colleague, who has done over 1,000 cases over a period of around 8 years, and has been found, the results have been found to be quite gratifying. After a good peribulbar block, the anterior capsule is stained with trypan blue, and then after filling the anterior capsule with the viscoelastic, make a small C-shaped incision with a cystotome, and using the cannula, you can just go underneath, clear up the liquefied cortex, just go underneath the base and just create a vacuum by pulling up the piston of the syringe so that it holds the capsule, and using a circular motion, you can just keep on making a capsular exis. Each time you have to just clear up the cortex and then go to the base of the rhexis, hold the rhexis with the syringe, creating a vacuum, and then you can complete the rhexis. The main advantage of this technique is that you don't have to come out of the anterior chamber, and you can just complete the entire rhexis without coming out of it, and even you can clear up the cortex, which prevents any visualization. This is another case where you have a calcified plaque, which is situated peripherally, and this CAN-back technique helps to easily navigate this area, and you can include that capsular opacification beautifully in this technique. This is another case of highly intumescent cataract where the chances of rhexis runoff is quite high. And after doing a C-shaped incision, which is very important, you can just complete and aim for a very small rhexis. And once this rhexis is done, you can just clear up the intralenticular cortex and reduce the pressure. And then the entire procedure becomes quite easy, as you can enlarge the incision using a Utrata forceps. And then once this amount of rhexis is obtained, you can always proceed with the phacoemulsification in the way you naturally do it. And then if you find that even after placing the intraocular lens, the rhexis is small, you can do a third rhexis using a rhexis forceps and a Utrata forceps. And the Vanas is to just extend the rhexis to get an adequate capsular wrap and to prevent any anti-capsular phimosis. So the main advantages of this technique are it is quite inexpensive. You get a good controlled rhexis without withdrawing the cannula, and you get both simultaneous aspiration and rhexis, and there are reduced chances of rhexis runoff. Of course, I won't say we don't get the runoff, but the chances are quite less. Thank you.
Thank you, Dr. Ravi, for can you stop sharing the screen? Thank you very much, Dr. Ravi, for showing yet another way of dealing with an intumescent cataract. It's just a thought that if with this syringe, the CAN-back rhexis, could you create a small one with the CAN-back and then go on to the larger one with the CAN-back itself? Or would you do the small one with the CAN-back and then go the regular way? I mean, it doesn't matter. It's just that I wondered whether you could do double.
I would prefer to do a smaller one with the CAN-back, and then once the intralenticular pressure comes down, you can just do a IA and reduce the pressure. And then, of course, the second step becomes easier.
And I think it's very important in these, when you're raising a flap in these intumescent cataract, is to raise a small flap and have it lying on the surface of the lens instead of being lifted up, because that itself could trigger off a rhexis extension, and then keep the re-grasping and grasping and complete it. I don't think there is too much of discussion in this particular case because he's shown a wonderful technique.
Ma'am, I wanted to know Ramamurthy sir's views on this vacuum needle process of doing capsular rhexis.
CAN-back capsular rhexis.
CAN-back.
Dr. Ramamurthy, before that, I wanted to know how easy or difficult it is to learn this, because to me it looked that you really need an expert doing it. Otherwise, you can get into trouble.
Technique. You have to hold the syringe in one hand and get the.
Oh, absolutely, I agree. As Ravi mentioned, Srish does it, and it seems to work well in his hands. I even talked to him, instead of aspirating with a syringe and holding it, why not use a IA aspiration cannula and use hold the edge of it and go ahead. But he says that, and I know that he does it routinely, He has even published on this, and it seems to work well in his hands. But I think it requires an extreme degree of control. And
even Shri Ganesh has been showing these videos of holding it with the bimanual. He does the enlargement of the rexes, and even the rexes he has shown in few places. But I think I tried doing it for a few cases. It's not as predictable as going with a micro rexus forceps from a side port and kind of holding it very close to where you want to do it. I think it gives me more control with the micro rexus forceps somehow.
And maybe an aspiration cannula would be a better this thing, because at least you don't have to be pulling on the syringe, and then if at all it's being done this way. But then, as we said,
maintain the anterior chamber. I just wanted to say, when you pull, how do you maintain the anterior chamber? I mean, once you have, is it filled with visco? And
keep going and refilling with viscoelastic. That's the way of doing it.
Left hand, but the left hand will be holding the syringe. I'm trying to visualize 3D imagine.
So you don't have to actually come out of it.
How will I try it tomorrow? That's what.
True. That made nice presentation, Dr. Ravi. We shall now go on to our next speaker, Dr. Tushya Om Prakash, who's a cataract refractive surgeon, a young surgeon in amidst us from Dr. Om Prakash Eye Institute, Amritsar, and of course a very innovative surgeon. I have been seeing him outbeat himself in each of these year after year. So on to you, Dr. Tushya.
Thank you, ma'am.
Ma'am, Dr. Jai Kelkar is not able to join because her connectivity is bad. So we'll go to Dr. Praveen.
Yes.
Good evening, everybody. I would be showing you my top pearls in cataract surgery. These are some of the pearls which I'm going to show you today. Coming to the first one is the chopper, which I use as a scaffold in hard cataracts. We published it recently last year. If you see in this video, this is a case of a black cataract where I'm going to use the chopper to my advantage. So if you see here, the side port incision is made 60 to 80 degrees from the main port to facilitate apt positioning of the chopper. The parts of the chopper which form the junction of the shaft and the tip, along with their adjacent parts, are primarily used as shields by horizontal placement anterior to the nuclear fragments. All the time, the surgeon focuses on emulsifying an anterior spilling nuclear fragments. He uses the foot switch in a controlled way and shadows the nuclear fragments with the chopper by using chopper shaft tip junction, and tip length to his advantage to prevent nuclear fragments from bouncing towards corneal endothelium. Clear cornea is seen on postoperative day 1. Coming to the next pearl, this is about the epinucleus, which is used as a scaffold in posterior polar cataract with the pre-existing posterior capsular defect. So this is a case of a young 32-year-old patient with a posterior polar cataract with PCR with no nuclear sclerosis. So no hydrodissection is done. Here if you see, layer by layer hydrodelineation is done simulating flags. BSS is injected at different planes and different directions to make sure that there is adequate nuclear epinuclear separation. Multiple layer phacoaspiration is done. At any given point of time, the nucleus is not rotated. Safe phacoparameters are used. With the aid of chopper, the outer nuclear layer is gently nudged and phacoaspirated. Throughout the surgery, the epinuclear shield, the epinucleus, acts as a shield to the posterior capsular defect, thereby preventing the nuclear pieces going behind, as well as preventing vitreous hydration. Before taking out the probe, visco is injected to make sure the bag is inflated. High sleeve retraction of the cortical tip is done. This makes sure that it separates the level of irrigation and aspiration, simulating a bimanual IA. The outer cortical layer is gently nudged from all the ends without aspirating. Once all the ends are completely freed, it is quickly aspirated. Coming to the third pearl, it is the AIOS scaffold technique, which is used to prevent the posterior capsule rupture in cases of Morgagnian cataract. So this is a case, a 72-year-old patient with a Morgagnian cataract with weak zonules and posterior capsule floppiness. So in this case, what I'm going to show you is, before emulsifying the last piece, the piece is gently taken out into the anterior chamber and the IOL is injected into the bag. This IOL acts as a scaffold to the posterior capsular bag, thereby preventing any bag emulsification. Secondly, the haptics of the IOL acts as a horizontal equatorial support. And thirdly, it helps in allowing the deeper plane phacoemulsification. So in this way, the phacoemulsification is completed. Thank you.
Thank you, Dr. Tushya, for defining scaffold in 3 different ways. But that was a nice thought. The first case with the chopper scaffold, I think the chatter which becomes less in these cases is essentially because we moved away from longitudinal phaco to torsional phaco, which itself reduces the chatter, and of course, increasing the fluid rate, there'll be greater fallibility of the nuclear fragments. So I think those have a bigger role to play. Just a very simple question. Would you think of one particular case where you can't use an IOL scaffold?
Where we can't use the IOL scaffold. In normal cases, we don't use IOL scaffold. We are in this particularly Morgagnian cataracts with the weak zonules and floppiness of the bag. At that time, we are taking the IOL as an advantage and preventing bag emulsification. But in routine cases, we usually don't use IOL as a scaffold.
The other thing was that wanted to come forward is IOL scaffold you would use definitely if there's a PCR below or in a Morgagnian cataract, where you want the Morgagnian cataract, you want the nucleus to have a base so that it doesn't keep rotating and hit the endothelium. And a PCR, you use it to have the nuclear fragment out. But if there is a small amount of zonular dialysis, those are those cases we would not use an IOL scaffold, because if there is a zonular dialysis is there, you may not be in a position to place an IOL scaffold because you don't know whether the zonule area of dialysis is going to increase. So
definitely, ma'am. Yes, ma'am. Yes.
Any other questions for him? Excellent presentation, Dr. Tushya.
Thank you, ma'am.
Before we go on to the next speaker, we do have a little bit of time as against what I thought, because Dr. Jay is not there. We have Dr. Praveen. Anything to ask, or shall I go on to Dr. Praveen's case? Okay. Our next speaker, or rather our last speaker,
Dr. Kelkar is not there.
Yeah, is Dr. Praveen Subudhi, young consultant from Ruby Eye Hospital, Behrampur, Orissa. With his teaching pearl, he has always had some very interesting tip to tell us. So let's hear from him. On to you, Dr. Praveen.
Thank you very much for this nice introduction. Am I audible, madam?
Yes, yes.
Yes.
Thank you, madam, for this opportunity, and thank you, ARC, for making me a better surgeon after 3 hours of these pearls. So this case is not a tough case, but it's a case to ponder. So I'll be sharing this case. Is my video visible? Cataract. Phakic IOLs play a very important role in correcting high amount of refractive errors which cannot be rectified with cornea-based procedures. In cases with biomechanically weak corneas, phakic IOLs are a blessing in disguise, correcting all amounts of refractive error. Various variants of phakic IOLs are available in international market, manufactured by Indian companies and as well as global companies, which has a very high efficacy rate and gives a very good post-operative vision. Basically, there are two variants of phakic IOL, one with a central hole and one without a central hole. The one without a central hole has a risk of developing post-operative intraocular pressure rise because of angle closure attack. Hence, laser peripheral iridotomy is very helpful in preventing any form of post-operative intraocular pressure spikes. However, this laser iridotomy has a risk of developing pain in the eyes, redness in the eyes, bleeding in the eyes, as well as sometimes accidental damage to the antral lens capsule, causing permanent loss of vision due to cataract. Here we present a case of posterior chamber phakic intraocular lens with peripheral holes and a laser peripheral iridotomy, which accidentally damaged the antral lens capsule, eventually causing a cataract. The patient was scheduled for explantation of the phakic IOL followed by phacoemulsification. We need to create a little bit larger incision, is more than 2.8 to 3 millimeters, for the smooth removal of the phakic intraocular lens. As these Indian-made phakic intraocular lenses are a little bit bulkier, it will be very difficult to remove of these lenses through 2.8. So it's better to create a 3 millimeter incision for the smooth removal of the lens. If you try to manipulate more while removing these phakic intraocular lens, you may accidentally damage the corneal endothelium that may eventually lead to corneal decompensation. Hence, we need to be very smooth, very gentle, and it should come in single shot, and we should not do multiple attempts. You can see here this lens was removed through a 3 millimeter incision in a single shot. Then I had to suture this incision and go to the temporal side to perform my phacoemulsification. Next, phacoemulsification is performed with a 2.8 millimeter temporal corneal incision. While performing capsulorhexis, you need to be careful to avoid the area of antral lens capsular damage. The rhexis needs to be away from that area so that you can get a continuous curvilinear capsular rhexis. As the lens was very soft, a gentle hydrodissection and free rotation of the nucleus was performed, and instead of using a phaco probe, with the help of irrigation aspiration probe, the whole nucleus and the cortex was removed easily. You can see here the whole nucleus and the cortex is coming out with the irrigation aspiration probe instead of the phaco probe. Removal of the residual cortex was ensured, and little bit of antral lens capsular polishing was done to prevent post-operative posterior capsular opacification. Intraocular lens was implanted in the capsular bag and followed by removal of the viscoelastic and formation of the chamber with the help of balanced salt solution.
Nice presentation, Dr. Praveen. So on to the expert panel. Any questions you all have to ask?
Before starting the discussion, the biometry which I used is the IOLMaster 700 and Barrett's Universal 2 total keratometry. The power which came was 9 diopters, but in order to give little bit of myopic for the patient to have a little bit of better near vision, I thought of giving a minus 0.75 targeted refraction. So I used a 10 diopter IOL instead of a 9 diopter IOL.
Do you have to do any correction for the presence of ICL there? For the Indian ICL versus the imported ones? Is there any, because it is a bulkier, is there any difference?
No, sir. While implanting, are you talking about while implantation, sir?
No. I'm talking biometric calculation.
No, sir. Nothing. It's the same. Whatever the targeted refraction, I thought it came, and the patient was happy in the post-operative period. The patient had a very good vision, almost like 90% distance, and she had a good vision for the near also. So whatever target I wanted, it came.
As far as the biometry is concerned, I think, the ICLs are about 50 microns, while The other lenses are about 100 microns in the center. And when you're using a laser interferometry, it hardly matters if the laser passes through that amount of thickness, and there's really no adjustment that you have to do, even if you're doing a immersion A scan. And beautiful presentation, Praveen. I mean, brought about a nice concept and nice discussion. I think, I mean, why blame the laser iridotomy for this? I mean, not only for these phakic intraocular lenses, but even otherwise, laser iridotomy is done day in and day out, and they very rarely cause a cataract like this. Of course, the vaulting of the lens is an important factor, and the fact that this particular lens did not have a central hole also has a greater propensity for a anti-subcapsular cataract. But during surgery, the reason for cataract being caused in phakic intraocular lenses is because of the viscoelastic removal. That's the step which is supposed to cause most often. So where you had the opacity was almost at the location where the side ports are made. So I believe that could have been one of the causes rather than the laser iridotomy creating it. And the second factor is that why is it that you made a 3 mm incision? You could have done your phaco through that itself. Why was it?
Probably there will be a lot of leakage. So there will be a lot of leak during performance of the emulsification. EC will be shallowing.
What I do in these cases, I do routinely a 2.2 to 2.4 millimeter incision. But in these cases, I make a 2.8 millimeter incision and use a purple sleeve right through. Basically, I make sure that the phaco tip that I use is also requires a 2.8 millimeter incision. And that ensures that the whole surgery is much more controlled and I can complete it through the same incision. The other factor, as far as the explantation of the lens is concerned, instead of bringing the entire lens into the anterior chamber, as Ashwin showed in his presentation, if you just prolapse out one of the haptics into the anterior chamber, nicely filled up with viscoelastic, and you can go in either with a 10-0 forceps or with a front-loading forceps that we use for loading the lens. If you can just grasp it and then the lens just folds upon itself and comes out. So that I think is the least traumatic way of explanting these lenses, but otherwise very well managed.
Regarding, sir, the Indian phakic and the Western phakic like the ICL, the thickness, as you said, around 50 microns, and the Indian lens are thicker. Is it easy to remove while it is behind the iris, or we have to remove both the haptics above that? Because while pulling it, you may accidentally damage the iris and it may cause a bleeding. That was my concern at that point of time.
This the ICLs are made up of Collamer, and the Indian lenses are made up of the same hydrophilic material. But the thickness of this material is much, these lenses is very much smaller compared to the intraocular lenses that we implant. And I have explanted both ICLs as well as Indian lenses, and these both of them come out quite comfortably through a 2.4 or 2.8 millimeter incision. You really don't need a larger incision. Routinely, I mean, not that I do it very often, but whenever I have to explant it, then I just prolapse out one haptic and hold it and bring it out and do my phaco also through the same incision.
Dr. Chitra, I would chip in by saying that, if I'm allowed to, that I agree with all the pearls given by Ramamurthy sir, and I would do exactly the same thing. The only thing I would point out here is that about, say, 10-15 years back, I was there to do live surgery for ICL at some point, and that time we didn't have the center flow. And the patient had already had a YAG PI done about a week before the surgery. And when I saw the patient on the microscope, I could see a focal cataract right where the iridotomy was. Somebody had been overzealous with shooting. And I used to think PIs don't cause YAG, laser iridotomies don't cause cataracts. And I could see the lenticular, opacification beginning to start. And, I mean, I was already into the surgery and I had no choice but to proceed. But I told the inviting surgeon that this patient is going to get a cataract. And 3 months later, that patient needed a cataract surgery. Patient went on to develop the cataract. So, I mean, that was the only time I've actually seen, opacification right behind the big laser iridotomy. And second thing that Dr. Ramamurthy sir said about, viscoelastic removal being the main step at which, you may end up causing a cataract is that last year or two, I've been totally using hydroimplantation of ICL, and it's really worked wonders because no IOP spikes, no kind of reaction next day, except that you should have done a couple of 100 ICLs and then you should switch to hydroimplantation, not as the first. It is more challenging, and there is also scope for more error. So definitely you need much more control. But that helps a lot, and it's helped me a lot.
Since we have the time, I mean, hydroimplantation is a great technique, Gaurav, and of course, in the hands of experienced surgeons like you, it will help. But in those who are a little more inexperienced, maybe using Heal-On or a cohesive viscoelastic will help, because
Right. Absolutely.
it's a dispersive viscoelastic. You have to go chasing after that and remove every strand to prevent any postoperative pressure spike, and that's when you could possibly touch the capsule. But if you have used a cohesive viscoelastic, the whole
Comes out
thing
more
just goes out as a bolus.
Absolutely.
And removal is very easy.
I agree.
What about the in cohesive viscoelastic, the 1.4%, 1.8%? What is the preference for you in these cases? It's more the one thickness and whether it comes out in a single bolus.
I frankly use whatever is given to me, but I think it's 1.4%.
So I think
also, Dr. Chitra, there was one interesting quick one which I wanted to show you. We had 2-3 presentations on Q%. I just wanted to show one small 3-second clip to, just I pulled it out specially for this one, and just if I can show you, just watch. I mean, considering that we prepare so hard for these cases, just watch. I'm going through a paracentesis and I'm hoping to decompress the lens. And so, sometimes you don't get a time to even, I just touched the lens and it kind of went away. So, I think femto is a great way to do these intumescents. I spoke at an oration in Hyderabad about 3-4 years back, and I was proudly claiming the same as somebody today claimed that ever since I started doing this, I've never had a Argentinian flag sign for last 3-4 years because I was talking about my techniques. And well enough, I came back, and 1 week later, I had this patient which I just showed, and I went in with all the precautions, and I just went in with good viscoelastic in the chamber. I went in from a fresh paracentesis with a 26 gauge, thinking I'll decompress it. Moment I touched the lens, I didn't have time to even kind of start doing the decompression bit. So when it has to happen, it'll happen.
It'll happen. That's as simple as that.
Is there any other questions my other speakers have to ask, or shall I go on to my concluding remarks? I think everybody is tired. It's been
concluding remarks now.
Yes. It goes without saying that it has been a top-class webinar with our speakers showcasing such wonderful cases in great grandeur. And of course, our expert panel have really done justice to the moment. And I'm sure each of us have learned from this particular webinar even more so. Our sincere thanks on behalf of ARC to all of you. Our thanks are also due to our able admin team led by Mr. Kripal, Mr. Sunil, who has been the webinar admin, and I'm sure all of you know how efficient he is. And we should not forget Sai and Manjula from Numerotech, who have always been our backbone for ARC in our activities. Our thanks are due to Entod for being our constant support and sponsors. And I'm sure all of us saw this video which Mr. Nikhil showed. It was so apt for the glaucoma week, which is ahead of us. And finally, and most importantly, our thanks to all our attendees who actually give us the energy to keep coming back with different webinars, and hope to keep challenging you even though we eat away your Sunday afternoon nap. Thank you very much. Thanks a lot, all of you. I'm sure you all enjoyed it.
We all enjoyed it. Thank you. Thank you. Excellent.
Thank you, ma'am. Thank you, everybody.
Oh, I forgot to thank Dr. Satyajit for being
easily I'm thought thank you जोर से बोल रहे थे.
Everybody.
Excellent.
Very nice. Thank you.
Not only
and great meeting everybody. Thanks, Dr. Chitra, and everybody else.
Thank you so much. Thank you.